Good evening, doctors and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by Amogs Medical Disorder Committee with Solapur OBGYN Society. It's my privilege to welcome the MOC of today's webinar, Dr. Madan Kambal sir. Sir is the chairperson of Amogs Aesthetic and Sexual Medicine Committee from 2022 to 24 and past secretary and president of Akluj OBGYN Society. I welcome you, sir, and I hand over the session to you.
Thank you, Saiti Madam. Today, Amogs Medical Disorders Committee has organized a wonderful webinar with Solapur OBGYN Society. And with the blessings of Amogs office bearers, President Dr. Rajendra Singh Pardeshi sir, immediate past President Nandita Palsetkar Madam, Secretary Dr. Sujata Madam, the President-elect Dr. Kiran Kurtkoti sir, and of course, the main master person behind this webinar, Dr. Sneha Bhoyar Madam, who is Amog Chairperson for Medical Disorders Committee and also past FOXI Chairperson for Breast Committee. I welcome you all, and it is privilege to have the wonderful and esteemed chief guest for today's session, respected Dr. P.K. Shah sir, who is past president of FOXI, and Dr. Suman Sardesai Madam, who is the great teacher, and she is teacher of mine also. She is professor of at HOD at PM Medical College Solapur, and also the guest of honor, Dr. Rohini Deshpande Madam, who is the past president of Amogs. And also, we are very lucky to have the esteemed speakers for today's session, Dr. Milind Shah sir, Dr. Monica Singh ma'am, and also the wonderful team of panelists and the chairpersons from Solapur OBGYN Society. Now I welcome Dr. Sneha Madam, who is the lady behind this webinar series and wonderful, having wonderful work in the Amogs and FOXI also. Shall we go for inaugural? Yeah, I invite all the dignitaries for e-lamp lightning. Thank you all. Now I invite and would like to introduce Dr. Sneha Bhoyar Madam. She is currently the chairperson for Amogs Medical Disorders Committee. She has won International MS Signature Award and so many awards she has in her name and so many publications. She has won the Anandibai Joshi Award also, and she was a past chairperson of FOXI Breast Committee. Also, she is governing council member, ICOG.
Thank you. Thank you, Madan.
Yeah. Yes, ma'am. Over to you, ma'am.
Yeah, thank you. Very good evening to one and all. Respected Dr. Rajendra Singh Pardeshi, the President Amogs, Madam Sudarta Darvi, Secretary of Amogs, immediate past President Dr. Nandita Palsetkar, and of course the incoming President Dr. Kiran Kurtkoti, the entire team of office bearers of Amogs. Today's chief guest for today's program, respected Dr. P.K. Shah sir, who is my mentor, guest of, and of course, Madam Suman Sardesai, a very senior respected personality from Solapur. Madam Rohini Deshpande, a very dear friend, and of course, past president of Amogs, under whose leadership we have enjoyed the tenure as well as the Andaman tour as well. And Solapur society is like my, my own society. So thank you, all of you, for joining. Of course, thanks to the president of Solapur Society, Dr. Vivek Virkar, and welcome all the esteemed faculties, Dr. Milind Shah, Dr. Monica Singh, all the esteemed panelists, chairpersons from Solapur, and of course, the coordinators, Dr. Monica and Dr. Madan, who are working relentlessly throughout India for me. So I welcome once again all of you. Just a few points about this today's webinar. As a Medical Disorders Committee Chairperson Amogs, I have been organizing these sessions all throughout India, and more than 100 sessions have been organized already, considering all the medical disorders on priority. But yes, we have definitely tried to accommodate some of the emergencies in obstetrics as well. This time we have included preterm labor. The reason being the highest incidence of preterm birth all across the globe, and almost 15 million is the figure. India being not only the largest contributor, but being topping the list of all the countries. Almost 3 million preterm births they are contributed by India per se, and they are responsible for almost 1 million of the perinatal deaths. And that is why it's a matter of concern. What WHO has reported is almost 3/4 of these preterm births and the perinatal mortality associated. It is preventable. And that is what we need to introspect, whether we can predict, we can prevent, and we can definitely reduce the perinatal morbidity and mortality associated. And that's the reason we have included this topic as the topic for today's program. I'm very happy that we got senior, most knowledgeable, experienced people as chief guests and guest of honor. I'm sure all the faculties will do justice for this topic. The topics by Milen Shah is also very very relevant. The kangaroo mother care, especially the breastfeeding in preterm babies, that is very important. And I'm very thankful to Dr. Monica Singh, who is associated with our Amogs for many of these programs. She has taken this challenge as antenatal interventions. Of course, she has prepared the topic solely because I have given her, and what antenatal interventions we can do as obstetrician to improve the perinatal outcome. So thank you everyone. Once again, welcome. And I take this privilege to invite my own mentor, Dr. P.K. Shah sir. Sir's CV itself is so crowded, but I just can say that Sir is a very senior, experienced Foxian, past president of Foxy as well as IHG, and dean of the Sonology School, and so many things. I'm not going to read. I better spare the time to listen to you, sir. Over to you, sir. Thank you.
Thank you very much for your kind words, Sneha. And good evening to everyone. It's nice to be a part of webinar now that there are so many conferences are happening, and we have continued with these webinars because there are so many doctors who cannot reach the places of physical conferences. So I think this is something superb that you are doing. And I thank Amogs Medical Disorder Committee, chaired by Dr. Sneha, with Solapur OBGYN Society, and the office bearers of Amogs, Dr. Rajendra Singh Pardesi, Dr. Sujata Dalvi, Dr. Kiran Kurtakati, Dr. Nandita. All these people have been doing this because I've been seeing this over a period of time, that there is a continuous input by Amogs. It is so nice to share this position of chief guest with Madam Suman Sardesai, whom you all know, for 2 gram magnesium sulfate for treatment of eclampsia. Also, it's nice to see our dear friend Rohini Deshpande, who is going to be the guest of honor. Again, kid from Solapur, a very bright person, Milen Shah, is going to talk on kangaroo mother care. Now, this is something which really attracted me towards this webinar, because I have been also, like Sneha, promoting breastfeeding. And it's so nice to see that an IVF specialist is going to talk on KMC, kangaroo mother care. Also, a constant factor K, Monica, for Sneha, is going to talk on antenatal interventions. and Sneha herself is going to cover preterm labor as panelist. And nice to see Dr. Girish Kumtekar as expert in her panel. So I'm sure all those who have joined us today are going to be greeted with fabulous academic inputs by all these people. And I thank Sneha and Amogs office bearers for giving me this opportunity to be with you all. As Sneha said about preterm labor, I think we have to be very, very, very serious about the situation that we are facing in our country. On one side, tons and tons of the uterine relaxants are given. And at the same time, we have not achieved much as far as preterm births are concerned and the deaths, perinatal mortalities are concerned. And I'm sure it is going to be cleared by Sneha in her panel. Thank you very much for having me with you all. Thanks a lot and all the best. And Sneha, wish you all the very best for all your future election. Thank you.
So thank you so much for your blessings. I know that you are always there for us, supporting and guiding us. Thank you so much, sir. I welcome Dr. Rajendra Singh Pardesi, the president of Amogs, who had just joined. And I would first invite sir for his blessings and words of guidance. Sir, sir.
Sardesai, madam, take Sardesai.
Okay, okay, with your permission, sir. So I invite Madam Suman Sardesai, whom you have just heard, the pioneer of, low dose magnesium sulfate or 2 gram magnesium sulfate. Madam is a revered teacher, teacher of teachers. Is 32 years in VMGMC, and of course the winner of Foxy Korean Award. All of you know her by her as by the various academic accolades what she has, and definitely we would like to listen to your precious words, madam. Over to you, Madam Suman Sardesai. Monica, please unmute yourself. Do we have Madam joined?
Azul, I think I cannot see ma'am, because
okay, so Madam was supposed to join in 2 minutes.
I will call up Madam again, ma'am.
Okay. So definitely we would like to listen to our own Amogs president, Dr. Rajendra Singh Pardesi, who has actually handhold and guided us in Amogs as well as Foxy. Sir, we would like to listen to your precious words, sir.
Respected Dr. P.K. Shah, sir, my mentor, always my mentor. My biodata doesn't complete without one line only. My biodata. I am disciple of Dr. P.K. Shah, sir. Dr. Suman Sardesai, Dr. Rohini Deshpande, ma'am, Dr. Sujata Dave, Dr. Kiran Kotikoti, Dr. Melin Shah, and our Amogs pillars, our chairpersons, Dr. Sneha Bhoyar, Dr. Umbardan, Dr. Madan Kamble, Dr. Minal Chidgupkar, and our friends, Dr. Manik Gurram, Dr. Gunjotikar, Dr. Virkar, and our guest, Dr. Monica Singh. So I congratulate again Amogs Medical Disorder Committee and Solapur. Solapur is a vibrant society for organizing this webinar. This webinar is very nice webinar, and it's really important to reduce maternal mortality. And we have taken place to reduce maternal mortality single digit. And I think Maharashtra will do. As Dr. P.K. Shah told, it's very important. And all kangaroo mother care, antenatal intervention, and preterm labor, they are very important topics. Again, I congratulate. And Dr. Sneha Bhoyar told me, sir, you have to be there. This is last webinar. This is not last program of Sneha. We are eagerly waiting for more programs from Sneha, more conferences from Sneha for her future endeavor in Foxy as Vice President, and also to Monica Singh for her future endeavor in Foxy as Chairperson for Perinatology Committee. Wishing every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you so much for your support always. I would say throughout last 2 years, whatever we have worked with you, and as you have witnessed, we have taken this Amogs to all over India, and we have covered most of the medical disorders. I'm very happy to share with you that with Sir's guidance, I have recently completed, and with the Amogs focus on medical disorders of pregnancy, and with all the revered authors, and it's going to be released at Amogs conference in Pune. I need all of your blessings for that. So now I invite Dr. Rohini Deshpande.
मॅम रोहिणी मॅडमचं घेऊ मॅम. मॅडम जस्ट घरी
Yeah.
पोहोचल्या, ते मिनिटात जॉईन होतात.
Okay. So, Dr. Rohini Deshpande, all of you know her as past president of Amogs, and of course, past president of Solapur Society also. She is known for
Thank
her
you.
academic
Thank you,
contribution as well. Yes, and a very humble and genuine, straightforward person, I would say, all the time supporting me also. Thank you so much, Rohini Madam, and over to you, please.
Good evening, everybody. It's very nice to see all of you, all Amogsians and respected Dr. PK Shah sir, Dr. Mrs. Desai madam, President of Amogs, Dr. Rajendra Singh Pardesi, and entire Amogs team, as well as President of SOJS, Dr. Vivek Virkar, and SOJS team. It's indeed a pleasure to be with you all for this important discussion on this preterm labor. I really appreciate Dr. Sneha for your wonderful work on medical disorders of pregnancy. And you have rightly chosen the topics of KMC, that is kangaroo mother care, as well as the interventions which are required for preterm labor, and of course, the panel discussion. Preterm labor, as we know that, it's been there for such a long time in our country, and we need to have really very concrete preventive strategies and identifying the preterm labor itself and diagnosis. And of course, the new molecules which are available, that also we need to use. And, use of magnesium sulfate, atosiban, all these interventions are very, very innovative, and I'm sure it will all be discussed academically in this webinar, and it will be useful for day-to-day practice for all the practitioners of obstetrics. I wish you all very best for this academic session, and I thank all of you from bottom of my heart and best wishes. Thank you, Sneha.
Thank you so much, madam. Saiti, can we have Madam Suman Sardesai's CV? I can see Madam just joined.
Madam has joined, ma'am.
Yes. Yeah, so I have already introduced Madam, but I will just say that Madam is a very senior obstetrician from Solapur, a popular teacher, and she is, her CV is decorated with so many accolades. All of us are very fond of you, Madam, and of course we are very fond of your regime as well, magnesium sulfate. We would like to listen to your precious words of guidance, Madam. Over to you.
Madam, please unmute yourself to speak.
I just saw her actually.
Yeah, Madam आहे, ma'am. She's connecting to the audio stream.
No, then, yes. Madam, please click on the join with audio, join with computer audio. Hello, Madam. Monica, you can talk to her.
Yes, ma'am, I'll call her.
Saiti, if you can help her joining with the audio.
Suman ma'am. Ma'am, please click on join the audio.
by the time Madam joins and blesses us, I would just thank all of you. Has Madam joined with audio? Hello?
Ma'am, I've just given her a call.
Yeah,
She's
yes.
trying to connect him.
Click on whether she can hear also, because she's not connected with audio, no? She will not be able to hear us.
Yeah. She's connecting to audio, Sneha.
But
I
she's
think,
not
yeah,
clicking,
we'll
no?
give her.
She's not clicking on that. Join
I
with
think she must have
computer.
clicked. There must be some internet issue, it appears. Now I think she's there. Yeah.
Madam, please unmute.
Unmute.
Ma'am, आता unmute करता.
Let Sahiti will unmute her, or
Yes, ma'am, I
Madam
have given
unmute her.
request.
Yes,
Yes,
ma'am
now,
has unmuted.
Madam, please.
Hello. Sorry.
हाँ ma'am, आवाज ऐकू येते आता.
Yes, ma'am, it's audible, ma'am.
Yes.
Madam, please बोला.
काय बोलू? नाही, at the outset,
तुमचे आशीर्वाद आणि मार्गदर्शन.
I congratulate Amogs Medical Disorder Committee and SOX for organizing this. And I must say, Sneha, you have been very consistently doing this nice organization of various this thing, and I wish you all luck and all the my team members of today's CME for very good deliberation. Okay.
Thank you so much, Madam. Thank you so much. I thank all the respected dignitaries who have joined and blessed us and definitely guided us. Especially Dr. P.K. Shah sir, Madam Suman Sardesai, Dr. Rohini Deshpande as guests for today's program, and of course my mentor, Dr. Rajendra Singh Pardesi, Madam Sujata Darvi, and the entire team of Amogs office bearers. I thank our seniors from Solapur, Dr. Girish Kumtekar, who is going to be expert for my panel discussion, and I can see Madam Sujata Darvi just joining in. Madam, can we have your few words, please?
Yeah.
I have already thanked everyone because sir had to leave this webinar. But please, over to you.
Yeah. I'm sorry that I could join in late because somehow or the other I was not able to join in. But at an outset, I would like to thank the organizer, especially Amogs Medical Disorder Committee Chairperson, Dr. Sneha Bhuyar, who is very hardworking, and she works very hard for everything that you assign to her, for arranging today's webinar. And today's webinar is on the topic of perinatology, which is very important, and we as an obstetrician play a very important role so far as newborn babies are concerned. I would also like to pay my sincere gratitude to our Amogs President, Dr. Rajendra Singh Pardesi, without whose encouragement and effort this is not possible. And we had a wonderful time under his leadership. I was not able to log in for the words of wisdom given by our chief guest, Dr. P.K. Shah, and Madam from Solapur, and of course, Dr. Rohini as a guest of honor. But I would like to wish best wishes for today's webinar and best wishes to Dr. Sneha Bhuyar for a future endeavor in Foxy. Thank you so much.
Thank you so much, Madam. And we declare that the inauguration is done for this today's program. And now I hand over the proceedings to Dr. Monica Ambadan and Dr. Madan for the academic session. Over to you, Monica. Thank you so much, everyone.
Thank you, ma'am. The first session will be conducted by Madan sir, and I'll be doing the second session.
Yeah, thank you, Sneha madam. And after the blessing from all the seniors, we are moving ahead with scientific sessions. Session 1, we have got dynamic speaker, Dr. Milind Shah sir, and the chairperson for this session will be Dr. Rajiv Dabde sir, Dr. Vivek Virkar sir, and Dr. Neeta Ghate madam. Yeah.
Please introduce the chairperson.
Yeah, Dr. Rajiv Dabde sir, who is a senior obstetrician gynecologist and IVF consultant, laparoscopic surgeon, and he is the director of Navjivan Fertility. He is assistant professor at OBGY, Ashwini Rural Medical College, Solapur. And Dr. Vivek Virkar sir, is currently president of Solapur OBGY Society. He is my teacher too, and he has presented various papers and won the best paper prizes at AISUG and Amogs. He is working at Virkar Maternity Home, Solapur. He was honorary treasurer at RCOG conference and also SOGS. Dr. Neeta Ghate madam, she is the president-elect for Solapur OBGY. Currently, she is working as consultant at Markandeya Sahkari Rugnalaya, Solapur. I welcome all the chairpersons for this session, and I hand over to, I request Dr. Dabde sir to introduce Dr. Milind Shah sir. Over to you, sir.
I request Dr. Virkar to introduce Dr. Milind Shah sir.
Yeah. Okay, sir.
Good evening, everyone. This is the thanks organizer of Amogs and thanks Medical Disorder Committee chairpersons for giving me this opportunity. So I think Dr. Milind Shah needs no introduction. He's a very dynamic personality. He was president of ISOBOB, past president of IMA, where he has won the best IMA Society prize, as well as he's the founder, president of Infertility High Risk Foundations. He was a treasurer of Asia Ocean Federation, vice president of FOXY, second vice president of Indian Society of Prenatal Diagnosis of Fetal Therapy, and he was chairperson for Rural Obstetric Committee, managing committee member of IAG. He was peer reviewer of Journal of OBGYN in India. He was past steering committee member, Asia Specific Abortion Pregnancy Abortion Partnership. He was past president of Solapur OBGYN Society. He was a national editor of member of FOXY. He has visited many countries, and he has presented in many national as well as international papers in conferences. He has contributed more than 20 chapters in various books, and he's a very active Rotarian. He is director of Naval Maternal Nursing Home, and I think he's a very dynamic and very active member of Solapur OBGY Society. So I request Dr. Dabde sir to say a few words about this today's topic.
I'm really very happy to have Milind in India and join us for this. Okay, I request Milind.
Sir, I'm in Solapur, sir.
I request Milind to start his talk.
Yeah. Thank you very much, friends. You know, when friends introduce you, it's always a pleasure, and that's how the Virkar was so elaborative. But I would say that I'm really very happy to have the chairmanship of Virkar as well as Rajiv and Neeta, a very close neighbor of mine. I must say big thanks, Neha, to you again, to, getting me this appointment to meet everyone actually from Amogs as well as the SOCs. In fact, I said yes to you, and then I realized I said yes to Insaj also at 7 p.m. So I thought I will finish with my talk, and then I can go for my another actually speech in my another group of the aesthetic regenerative gynecology. I'm really happy to see the contribution of the Amogs Disorder Committee, Sneha, which you are leading, with all those leadership by Rajendra Singh, Nandita, Kiran, as well as Dr. Sujata. More so, I was impressed to see the mentors of my life in my actually the field of OBGYN, Dr. P.K. Shah, and my own PG teacher, Dr. Suman Sardesai madam, having here, and I feel it's honor for me. Rohini and we were like siblings because Dr. B.B. Kulkarni always used to look after us as the kids, and we used to get ourselves nurtured in our clinical practice because of him. So I'm really happy to have all of you, and I'm very sure the Monica, you're going to have a lot of fun here. Monica Singh from Bhopal, because Now she's my Samdan because of Madhya Pradesh. Monica and Madan, always and always, both of you are very active organizers. I know that Monica was getting a lot of appreciation in the AICJ. Monica Umbardan. There are two Monicas, yes. So with this, let me come to the today's very important topic of kangaroo mother care. Can I share my slides, please? Let me see whether I am able to share my presentation. Yes. Yeah, is it the slides are seen?
Not yet, sir.
Not yet, sir.
Not yet. Acha. Just give 1 minute and it will appear.
So they're seen now. Can you make it full screen, sir?
Yeah, same thing I'm going to do. Yeah. So friends, people always think that childbirth is so easy and looking after that baby is also equally easy. But we all know that it's not a very easy job when it comes to the high risk of obstetrics or when it comes to prematurity. And that's why I was very happy to have this particular topic once again with you all, though quite few of you must have heard about this, the kangaroo mother care. We realized the importance of it during the COVID days because we realized that when those COVID positive mothers used to deliver, we always had a question whether we should allow the baby to be in the lap of the actually mother because we were worried that this infection may cause some problems to the baby as well as the to the mother as well by avoiding breastfeeding. But eventually, when we realized that suppose we adopt all those gears, protective gears, it was very easy to see that the baby can be very much with mother as well in those COVID days. So friends, it's always our great struggle in the medicine these days is not just with ignorance and uncertainty. It also with this all this complex situation that how much you have to make sure that whatever you have in your head and think about it, there are thousand ways things can go wrong, and that exactly happens when it comes to the looking after the term as well as the preterm babies. Now it is always a question asked that when it comes to the KMC, is it the onus of only pediatrician or the neonatologist, or whether the obstetrician also should take lead in that? And that's what I'm going to share with you what we do in my clinic, what we do in our country, what we do internationally as far as the kangaroo mother care is concerned, and how we can improve our obstetric care. So it is not the debate of who, that is obstetrician or the neonatologist. Anyone can, including a lactation nurse or any midwife who can definitely do that. Probably you all must be aware there is a Kangaroo Mother Care Foundation in India, and I was lucky enough to chair that inauguration of this KMCon in 2017 when I was president of ISOPA, and that's how I got attracted to this particular topic when Dr. Shashivani, who is very actively actually promoting Kangaroo Mother Care all over the world, where I wanted to work upon. And then eventually, very next year, we had a meeting in Manila. That was, I think, AOFOG meeting, where we formed this particular group called A to O Network, where Kangaroo Mother Care we wanted to propagate to all those countries where people were not much aware of the importance of this Kangaroo Mother Care. And then we started more actively, not only in our country, but all those Asia, Oceania region, because we realized there are n number of system bottlenecks. There were some potential solutions also for that, which we are going to discuss under this particular aegis. This is a wonderful paper, which was a multi-country analysis of health system bottlenecks and the potential solutions for the kangaroo mother care. And what they said, yes, there are many KMC programs, but still there are certain pathways we need to scale. That is champion led, project initiated, and the health system design. There is need of the scale up of all these things because there are problems by which the things can go wrong at every level, and the preterm babies may get suffered as well. This is a wonderful actually news again of kangaroo mother care endorsed by major pediatric, obstetric, nursing and midwifery associations, where they realize the importance of it, and now worldwide people are thinking about this particular skin to skin contact of the baby to mother, baby to father, baby to all family members. It is very powerful and easy way to use method to promote the health and well-being of low birth weight baby, preterm infants, that is infants with gestational age less than 37 weeks. But I would say little one step further, even for the term infants, what I have realized. It is first introduced for the low birth weight babies surviving the first few weeks of life, where the apart from skin to skin contact, exclusive breastfeeding was encouraged. As long as infants could feed and were gaining weight, they were discharged regardless of the weight. Because otherwise, we used to say that the baby need to attain a particular weight before leaving the NICU or the obstetric unit. But now we have realized that what is important is suppose we give this natural incubator to the baby, which is more economical, more easy as well, and which has resulted in the improved outcome for the low birth weight, humanized general care for the infants in the hospital, decreased hospitalization time, less overcrowding, and less abandoned infants. So why this name actually was given as a kangaroo mother care? You all know about the baby kangaroo because very famous picture even in our nursery days is shown to our babies or even to us when we were very young like Joy, where very immature and very small in size baby kangaroo sits in the pouch which gives warm, safety and constant supply of food to the baby kangaroo. Similar to kangaroo care, giving the human infant is also immature, and especially for the low birth weight infant benefits from this contact. It provides all those things like warm, safety and food. People always think that is only this position which is important. Yes, this position is very important where we give to skin contact to the mother's chest by securing the baby with a wrap. But the other components of kangaroo mother care are also very important, which we promote. The kangaroo nutrition, that is exclusive breastfeeding, kangaroo discharge, that the mother continues this practice at home after discharge. Healthcare staff provides support to the mother to take care of the infant in the hospital. Family support of the mother in practicing KMC at home as well is equally important. And that's why what I have started doing that I designated one particular nurse in my hospital who works as a lactation nurse, and she looks after exclusively the breastfeeding, where whenever there are certain situations, there are problems, she goes to that particular room or the ward and teaches actually mother about the breastfeeding. Additionally, she also teaches all others when there are no patients or when there is a little time in the hospital. Now, this binder is very, very important, and this binder always gives a support, and you will find n number of such binders available. The one which you can see in this picture is designed by me itself, and you cannot believe from whom I got it. Probably Madam Sardesya will be happy to know about it because she was one of my patients who is a tailor in Ashwini Hospital. And when she delivered, she told me that she is now working. She goes on bicycle to Ashwini Hospital. Her name is Muddebi Harkar, and then she used to do all that stitching work for the Ashwini Hospital. I told her, yeah, can you please stitch for me certain suits of this kangaroo mother, which is very simple, putting those strings to a particular cloth with little designing. And she was extremely happy, and eventually she told me that so many other doctors in the city of Solapur nowadays are availing this particular suit and utilizing the nursing home. And I felt myself so happy that see, a very small intervention can make a major difference not only to me, not only to my patients but also to herself to get more and more empowerment when she was really in need of that particular thing. The healthcare staff support in the hospital not only for breastfeeding or the skin to skin contact, but also emotional support. The mother needs encouragement. Quite often they get frustrated, especially in nuclear families. We find that they are unable to cope up with all those difficulties in the lactation. For obstetricians, we may feel that it is not very important, but they are equally important. Teaching mother the skill to take care of their low birth infant is very important, and after discharge infant need the regular follow-up to check satisfactory weight gain at clinics close to home. Support from the family at home is very important, because then we need to teach all those nannies, in-laws, as well as other family members about this kangaroo mother care. And that always goes a long way. I remember once we had this wonderful meeting on the day of World Prematurity Day at one of the very good clinic in the city of Solapur at Span Hospital. And we realized all those mothers were so inquisitive. They wanted to ask n number of questions about kangaroo mother care, breastfeeding, as well as all that care we need to give. Then I realized it is not only we, but many of our Amogs societies are doing this wonderful work. When Dr. Bangal from Loni, he sent these photographs to me, which are now on the website of international organization of this KMC Foundation, where he actually teaches all those youngsters, the nurses, the students, postgraduates about the kangaroo mother care and all other care one need to take for the premature babies. The nurses, they may take very equal and very good role in giving the practical training to these particular patients as well. The things never end that way. We need to do a lot of public awareness as well, because quite often now we have realized unless and until we reach actually these patients in very positive way with the help of our media, it won't be that effective any particular intervention or new ideas to be inculcated in the society. So this supportive environment is very much essential from all those angles for kangaroo position, kangaroo nutrition, and the kangaroo discharge, which is a benefit not only to that particular baby, it is beneficial to the mother, also it is beneficial to the hospital as well. It is beneficial to the obstetrician as well, because it significantly saves the cost for the better outcomes. Probably pediatrician would say, but nowadays pediatrician also promote a lot kangaroo mother care, where we can have less dependence on the incubators, less nursing staff necessary, shorter hospital stay, and improved moral and quality of care for the better survival of the baby. It decreases neonate and infant mortality and morbidity with the very simple, applicable, cost-effective intervention, resulting in healthier and the most intelligent baby. We need to, of course, follow just by educating KMC should not stop. We need to have a proper charts to be kept with the patients. You have to tell your neonatologist where we need to see that they should always follow this, and even WHO recommends this particular care for the clinically stable patients. If it is given continually for both day and night, it can be discontinued for short periods when the mother has to bath or attend other personal needs. In academic practice at both places, as I told you, requires support and is the ideal type of KMC one need to do. Now, the another thing which I started doing, because there was a terminology previously I got introduced in my foundation that KFC they used to call kangaroo father care, but now the nomenclature has changed. Now they say KMC dash father, because now father also can take equal role, because there were so many actually problems related to the family involvement, and the maternal mortality situation always remain precarious in the developing world, where using this mantra of male involvement and responsibility in the women's reproductive health makes a major difference. So what we have started, that we tell our husbands, because nowadays the husbands they do come in the clinics as well, in the labor room also, in the theater also, for attending the childbirth. We tell them now you also need to give this kangaroo mother care, whereby they can put the baby to skin contact to them and the babies get actually benefited with the kangaroo father care as well. And you cannot believe, friends, it makes a major difference as far as the joy, the enthusiasm the fathers they get. And they always feel themselves so actually important. They feel, yes, nowadays, otherwise, so much of Mahati we know about the Matrutva and the mother and baby. But yes, father and baby is also equally important as all you know. And there are so many fathers as well in this particular webinar, so they also get involved in this particular program and makes a different actually change in their families, which brings more family ties, better parenthood, confidence building in the children and wife, and humanly approach towards the family, which is a major change. And that's why we always promote this with the help of again with various media. People ask whether we can give KMC when the baby is in the NICU. Yes, certain duration can be incorporated for the KMC, and nowadays pediatricians do that. In NICUs, where actually I keep my babies in the Ashwini Hospital or the Yashodhara Hospital, they always promote this KMC for even NICU babies for the short duration. Not only that, now even for ventilator babies, they say that if it is possible, if the intensivist or the neonatologist is comfortable, the KMC can be given that way as well. And probably you must be knowing this recent change in the Safdarjung Hospital, Delhi, which was a flash news on various media on the television as well, whereby they started the mothers to be kept in the NICU where the baby can be very close to the mother while availing all that NICU care, which is a major change and which was taken very well by the entire world. And I'm very sure that the conventional care is always recommended for the newborns for the all actually possible ways what by which we can do that. So friends, kangaroo mother care is the basic right of the newborn and should be an integral part of the management of low birth weight and the full term infants in all settings at all levels of care and in all communities. It is very, very essential to see how actually we can propagate. Now, we are coming across more actually in the coming 2-3 years, 50 plus CMEs across the nation over 3 years on various aspects of neonatal care. And one of the important talk incorporate is the kangaroo mother care. So we have given actually the slide presentation to the group, and similar initiatives need to be taken by other groups as well, which will be well supported. And Sneha, that's why I must say you a big congratulations because you thought about this particular topic, which is equally important to be understood by all our obstetrician friends, all our Amogsian, all our Foxians on this very important topic. Thank you very much, friends, for your patient listening. I'm very sure there may be certain questions as well. I'll be happy to have the answers to all those questions related to the kangaroo mother care. Once again, I must say big thanks to Sneha to you for this wonderful opportunity. All Amoxians, all my teachers, all my friends from the Solapur Obgyn Society, who always and always support me for these endeavors and the blessings I receive from my all seniors. Thank you very much.
Thank you, Vinny. In fact, that was an excellent talk, I would say, and really very much needed for we obstetricians. I think breastfeeding is even today a neglected topic, and breastfeeding for a preterm baby is still more neglected. So thanks to you, especially for that. Over to the chairpersons for their comments.
Thank you, Milind. Really wonderful talk. And as you said, in Ashwini, NIC also we are practicing this kangaroo care, and our neonatologists are really very happy with that concept.
Thank you, Dr. Milind Shah, sir. Kangaroo mother care at informative talk, and so much informative about the design of kangaroo suit for mothers by tailor in your own hospital. I really inspired by Milind sir. All the time he's finding new thing for the mother and baby, and he's doing great job in public awareness. World Premature Day in span, and all public awareness talks are given by Milind sir in spite of his busy schedule. International speaker as well as home speaker. Thank you, Dr. Milind sir.
Yeah. Yes, thank you very much, Rajiv, Vivek, and Nita, for all your comments, and I'm so happy. But let me tell you, Sneha, that our society is a very vibrant society, and every year we find that the milestones keep on increasing, and that's how the Vivek is doing such a wonderful work today. So, Vivek, congratulations on more feather your cap of this particular webinar, and thank you very much for this invite. Thank you.
Thank you, sir.
Thank you, Milin Shah sir, and thank you, Dr. Dabde sir, Vivek Virkar sir, and Ghate madam for chairing this session. I hand over to Dr. Monica for session number 2. Yeah.
Thank you, Madan sir, for an excellent coordination in the first half. Thank you, Sneha ma'am, for an opportunity to coordinate the Solapur OBGY webinar with my own mentor society, with so many stalwarts being at my back always. Let me take pleasure in inviting the chairpersons for today's webinar, Dr. Zamre madam, Guram sir, and Gunjatikan madam for this session. Can we have the CV? Yeah. Madam is a very senior obstetrician and gynecologist practicing in Solapur. She has worked as a lecturer in VM Medical College and an honorary consultant at Fortress Memorial Hospital. She is also working as a consultant in her private nursing homes in the last 35 years and has been serving the society at various capacities. We welcome you, ma'am. I take privilege in introducing our next chairperson for the session, Dr. Manik. Am I audible?
Yes, ma'am.
Hello? Yeah. Sir has been as a past executive member, president of the Solapur OBGY Society as well as IMA. And he has received the Best Society Awards at both the positions. Sir is also the chairman at Sri Markandeya Solapur. That is what I can see, the modest and the most humble person in Solapur OBGY Society that you will see, ma'am. Dr. Meena Gunjatikan madam is a current secretary of Solapur OBGY Society, and she has been in private practice since the last 18 years. She is also an honorary consultant at SSNJ Ayurved Hospital. We welcome you to conduct this session by lecture by Dr. Monica Singh madam from Bhopal. Zamre ma'am, can you please introduce madam?
Monica?
Haan, ma'am.
You can listen to me?
Yes,
Yes,
ma'am.
yes.
You're audible.
Yes, Madam Zamre, welcome. We
Yes,
can
yes.
hear you.
Thank you, Sneha. Thank you. So we are coming to our second lecture now today. Today's a very interesting topic for everybody, all obstetrician, and we have a very able person to talk on. We have antenatal interventions to improve a perinatal outcome. And for that, we had today's speaker, Dr. Monica Singh with us. And she's an ART, I have to introduce her. She's an ART specialist and an owner of an Bhopal test tube baby and maternity. She has a very long and very interesting biodata, and it's very difficult to read all that. But select.
No, madam, it's not required, madam. It's not required at all.
No.
It's enough that I have got a session to speak on in Amogs because of respected Dr. Sneha Bihar and Dr. Pardesi sir, and that is all the introduction I will be needing.
I want to introduce few of the things. She was the organizing secretary of a very prestigious 27 annual ISOR conference in Bhopal. And so many reward awards she credit to, lot of publications, lot of chapters in the textbook. I think, Monica, you are the right person for this topic today. Please start.
Thank you so much.
Guram sir, can you introduce the topic, please, for us today?
Yeah. I will take 1 minute. When I asked regarding this, accepting the chairperson, the topic which was very interesting. And because of that topic, I said that I will be their chairperson for this topic. Because for a mother, the best gift is a healthy baby at the end of the pregnancy period. But sometimes this may not happen. And because of some complications in form of environmental aspects or nutritional aspects, there are some morbidity and mortalities in the mother and baby. And as an obstetrician, we need to do some interventions to reduce the stillbirths and improve the maternal and neonatal outcomes. So there are several key antenatal strategies that aim to prevent the stillbirth. And let us hear from Dr. Monica Singh details about this topic, because woman's health is a nation's wealth. Because if woman is healthy, then the fetus will be healthy, then the young person will be healthy, and the nation will be healthy. Please, over to Dr. Monica Singh.
Thank you so much, Dr. Guram sir. I thank all my respected chairpersons, Dr. Sulbha Zambre ma'am, Dr. Mani Guram sir, and Dr. Meena Gunjotikar, with whom I talked a couple of months back for my own sessions. And since I am a very happy person to be in Amogs webinar today, I would like to extend my warm thanks to Dr. Rajendra Singh Pardesi sir, who has always supported me. Despite not being a part of Amogs, I feel like I'm a part of Amogs because of two people. First of all, my elder sister Sneha ma'am, and second because of Pardesi sir, who always, is so warm and affectionate. In any part of India, I meet him, he remembers and he talks like it is yesterday. I also would like to extend my thanks to immediate past President Dr. Nandita, Secretary Madam Dr. Sujata Dalvi, President-elect Dr. Kiran Kodkoti, and AMOG's Chairperson Medical Disorders Committee, Dr. Sneha Bihar. I would also like to thank Dr. P.K. Shah, who has taught us basics of ultrasound. He came to Bhopal, GMC Bhopal, my alma mater, I remember, when I just entered private practice, and he has been teaching so beautifully ever since then. Half of my 90% of my interest in ultrasound is because of my mentors. One of them is Dr. P.K. Shah. I would also like to thank Dr. Suman Sardesai, ma'am, who is our chief guest, and guest of honor, Dr. Rohini. So, without further ado, now I would take permission to share my screen. I'm not able to share my screen, madam. So I think I will just.
Saiti, can you help Dr. Monica?
Saiti, actually, I had put I put my slides open, but somehow it's got
You
many.
click on the slide share screen icon. Yeah.
Yes. Now I have put my slides on, so I should be able to share.
Monica, just have you opened your presentation?
Yes, ma'am. I just did open my presentation.
Now you reduce it. You minimize it, and now you share the screen. Click on share screen icon. Saiti, please see whether she has some technical issues. Are you clicking on the icon?
Yes, ma'am. Actually, this is a new Mac I'm working on, so it is giving some teething problems to me. But if the technical support can guide me.
Monica, ma'am?
Yeah. The webinar, my slides are open on my screen, but I'm not able to see the slides when I press the share screen option. So I'm going to Windows, I'm going to Chrome tab, I'm going to entire screen.
Ma'am, while sharing the screen, there will be like on topmost left, there is screen tab. Yeah, you can click on that and share the screen so that whatever it's there in your desktop, it will be visible.
There are three options: Chrome tab, window, and entire screen.
Share entire screen, and then we see the presentation.
Share entire screen, you will be able to see the.
Share entire screen, Monica.
Yes, ma'am. I'm doing that. No. This screen only is becoming visible.
You can mail me the presentation. I will share from my side.
Right.
Immediately, you mail me.
Yeah.
I have sent my mail ID also, ma'am. You can send it to me. I will share.
I'm sorry for this technical glitch. I don't know why it's happening today. So I'll just.
drsnehabuyar@gmail.com. Share with me, no worries. Have you mailed, Monica? Should we go for the panel discussion and then you will do it again?
Ma'am, in the meantime, you can start talking if you can see. In the meantime, we will try and open your PPT if it is possible. Otherwise, we carry on with the panel discussion, ma'am. Monica, ma'am.
He must have gone for some help, I think.
Hmm.
So I think, should we go for panel discussion? Otherwise, by the time she can
Yes,
solve
ma'am.
the problem, no worries. Should
Yes,
we,
ma'am.
do we have
Saiti, can you
all
call
our...
her? Yes, Saiti, can you call up madam and do the needful in the after I introduce all the panelists?
Okay, ma'am. Okay, ma'am.
Yeah, Monica, you can start introducing so that, you know, we start with the panel discussion. Yeah.
Can we have the slides, please? Saiti? I welcome all of you to the very important panel discussion of this webinar, which is the highlight, which is on preterm labor. This session will be moderated by none other than Sneha madam, who has been already introduced just before we started this webinar. I would like to introduce Dr. Girish Kumtekar sir, who is an expert for this panel discussion. He is a consultant and infertility specialist and a medical legal consultant in Solapur in the professional practice since last 35 years. He has been a past medical legal and ethical committee member of FOXI, the past medical legal committee member of the IMA state branch. He has been the past president of Solapur OBGY Society and the faculty at various national and international conferences. We welcome you, ma'am, sir. I take privilege in introducing all our panelists for today. Dr. Pratibha Baldeva is a gold medalist and a fellow of American College of OBGY. She is a consultant at SS Baldeva Hospital and a director at Baldeva Fertility Point in the Test Tube Baby Center. She has held various positions in the society from the year 2017. We welcome you, Pratibha. Our next panelist is Dr. Nisha Kotwal. She has 3 gold medals in her dojo and she's practicing in Solapur since 2011 and a consultant of the owner of Kotwal Nursing Home. Our next panelist is Dr. Saman Tamburi. She's a consultant at Tamburi Clinic and Max Hospital. She is also an international board certified lactation consultant. We welcome you. Our next panelist is Dr. Meenal Chidgutkar. She is the director of Chidgutkar Hospitals Private Limited and a senior infertility consultant at Apollo Fertility Solapur. She has 12 years of experience in infertility. We welcome you. Our next panelist is Dr. Ashwini Pawar. She's a consultant gynecologist practicing in Solapur since last 15 years, and she's the director of Omkar Nursing Home and at Sunrise Hospital, also the director at Sims Fertility Center. We welcome all of you for the panel discussion, and I request Neha madam to please go ahead with the panel discussion.
Yes, thank you, Monica. And Saiti, if you can stop share so that I can share my screen. A very good evening to all of you. आणि माझा नमस्कार गिरीश कुमटेकर सरांना. We are very happy to have you as expert, sir.
Thank you,
and, I hope you can see my slides.
Yes,
Yes. So I welcome all the panelists. Already they have been introduced. You know, I always say that my introduction, rather than having so many national and international awards, I would always prefer to get introduced as a hardcore obstetrician because I'm a private practitioner since last 32 years now. And I always like to be very genuine and, you know, as work at a grassroots level. Whatever problems we have to face as a practicing obstetrician gynecologists, we really have to deal it practically. And that is why I have prepared this presentation. And we are here to discuss what is right and not to argue who is right. So I'm very happy. I have already talked about this preterm labor being a very, serious matter of concern, because of the 15 million preterm deliveries across the globe, almost 3.5 million preterm births are by India, contributing to more than 1 million perinatal deaths. And that is why we are not only amongst the first 5, but we are topping the list in the world. So that's a matter of, to be ashamed of. All of you know there are so many, so many of these etiological factors and all this, but then we will talk about the very, case-based discussions. So without much ado, I would straightway go to the case discussion. And here we have this, if you allow me, let me just stop share and, let me see whether this is the same presentation. I think I have also some problem with my presentation. Just one sec. I will start with the panel discussion, and whosoever, I'm sharing my screen once again. So what technical problem today? Yeah. So we have this young lady, 28-year-old primary gravida. She's reporting to you during her 8th month, 31.5 weeks gestation. And she presented to you at about 3 a.m. with the complaints of pain in abdomen. When you examine, you find that her pulse rate is normal. She's afebrile, but her blood pressure is 120/90. The uterus is 32 weeks, slightly irritable. Fetal heart is good. When you do her internal examination, cervix is posterior, os is closed, os is just admitting tip of finger, and cervix is short. There is no show, no leaking. So what is your diagnosis and how would you go ahead with the management? Okay. We can start with one end and we can go to the other. Anybody can take up this question.
Madam, I feel this is, we have to first rule out that there are no Braxton Hicks contractions or it is not false labor. So,
yeah, so I directly stop you here. She's complaining of abdominal pain. So how do you differentiate the Braxton Hicks contraction from labor pains?
Braxton Hicks contractions are actually false labor pains. They get relieved with rest by changing a
but
position.
But they're painless. That is the basic thing. Braxton Hicks contraction is the patient doesn't feel anything. When you examine, you find that the uterus is little contracted, but the patient doesn't feel it. So painless uterine contractions, which themselves become gradually more in intensity, and then the patient starts getting pains. So you have your own answer. It is not Braxton Hicks contraction because the patient has come to you with pain in abdomen, and why at 3 a.m. she will come to you with Braxton Hicks contraction. Okay. So
the diagnosis in her case is mainly preterm labor, and basically I'll try to get her admitted and then evaluate for the cause.
Now, once again, I stop you here. Whether it is a threatened preterm labor or an established preterm labor, because you have all the findings here.
It is threatened preterm labor, madam.
Okay. How do you define that? How do you differentiate, I would say?
Threatened preterm labor is when there is just contractions without obvious frank cervical dilatation, because in her case, the cervix is not dilated. There is no show and no leak.
Correct. So the menstrual cramp-like uterine pain, that is what a classical pain, when you have, the pressure in the lower abdomen, cramp-like pain, dull aching abdominal pain, or maybe there is some change in the cervical or vaginal discharge, and of course the progressive cervical changes. That is what you call it as labor per se. But then when you say establish, what should be the dilatation?
Dilatation should be at least more than 3 centimeter. They should be associated with leaking or with
No, not
show.
necessarily leaking. Why should a labor will be always by leaking?
But the cervical dilatation has to be there. Cervical
Yes,
dilatation
progressive cervical
with uterine contractions.
which consists of cervical softening, effacement, and dilatation. Right?
Yes.
Okay. So you
And which is
mean to
progressing
say,
with contractions.
okay, okay. You mean to say she has got threatened preterm labor?
Threatened preterm labor.
Yes. So you have been given with the findings of internal examination.
Yeah, can I interfere for a
Yes,
minute?
yes, Girish sir.
The first
I'm
thing
going
and
to
first
ask
and
you definitely the comment, but yes, you
the
you
first
can.
and foremost thing one must do is to rule out other causes of abdominal pain. That is
Correct.
the first and foremost thing you must do before even thinking of preterm labor.
Yes.
That's what I would advise.
That is what we have said, that very classical pain, when you say it, if it is like this, then only it is a uterine pain and associated with cervical dilatation.
Yes,
You're
it
very
has to
right.
have effect
Yes.
on cervical dilatation.
Yes, yes. That is what we are trying to say, that you have very rightly discussed it or described it, and you have to rule out other causes of pain. As you said, false pain. But then other causes of medical surgical reasons also for pains can be. And that is where the role of evaluation. So proper history, what kind of pain she has, whether it is associated with regular uterine contractions and the progressive cervical changes. And then, of course, the question comes whether you should try and conserve or whether she needs a treatment. Now tell me, what is your management for this patient?
This patient is having abdominal pain mainly, but there are no cervical changes. So basically, get her admitted, try to relieve her pain. This can be done by the use of tocolytics because their uterus is irritable. And we can give corticosteroids because she's only 31.3 weeks for fetal maturation.
Yeah, so basically, you don't want her to progress to the frank labor, preterm labor, and that is why you have to, go for whatever symptomatic management she needs. And of course, you want her to take her continue the pregnancy till the period of salvageability at least. So do you straightway go for some tocolysis that we will be discussing? But before that, do you want to evaluate her? What information we have is only that she has pain, and when you do internal examination, there is no dilatation. But is there any role of ultrasonography? Do you want to see whether this baby is safe inside? Whether
Better
you
to
really
do,
need
yeah,
to,
better
yes.
to do an ultrasound with Doppler at this stage to know what is the fetal status, the light curve, and the blood flow to the baby, the estimated fetal weight that is there at this point of time. Also, her blood test can be done to know whether there is any infective pathology. A CBC, a WBC count would inform us whether there is any infection, underlying infection.
Perfect. So it is not straightway directly, talk about only focus your mind to the labor pains, but you see whether the maternal condition is stable, whether she has any problem. You see whether the fetus is well in utero, and if you continue this continue this pregnancy ahead, whether the baby will suffer. That you have to know. Okay, so definitely you have done. Now, what kind of management you want to do for this patient in particular? Bed rest?
Yes, ma'am. I would like to admit this patient, give her bed rest. Actually, the role of bed rest is slightly doubtful many a times, because many a times labor may progress spontaneously, so even giving her complete bed rest, only just
Do we
moments or
advise complete bed rest, or do we advise only pelvic rest and certain instructions, or how?
usually we advise actually with bed rest, with many a times we give head low also to avoid pressure on cervix, and yeah, and definitely we admit her to reduce her stress, because many a times even we tell patients to take rest at home. Patient don't follow our instructions at home. They have a lot of work. They can find work at home, and they just again land up in they can land up in active labor also.
Okay.
Yeah.
Okay. So, someone, do you want to comment on the tocolytics? whether you really want to give this patient tocolysis and what kind of tocolytics you would prefer.
Ma'am, in this patient, I feel because there is no cervical dilatation, if analgesia is relieving her pain, if the cause, see, because the cause of these threatened preterm labor is
She
called
does have
uterine
uterine contraction.
She does have. So, ma'am, my drug of choice would be nifedipine in this patient.
Okay.
And if it is not relieved, then I would like to go for ritoxiban. But that is my second choice.
Yes. Okay. So definitely tocolysis. Now comes till when? Till when?
Ma'am, till 34 weeks. Till at least we can ensure.
Tocolytics.
Tocolytic till the contraction cease.
Okay. Okay. So no. Tocolytics. What is the end point of tocolytics? Anybody from the panelists?
Ma'am, it is
I'm going to ask Girish sir.
48 hours till we can shift the baby to a center, fetus to a center where it can get appropriate neonatal care. Ma'am, if it is
Sujata, do you want to comment here? Tocolysis till when?
Yes, madam, up to 48 to 72 hours. Actually, role of tocolysis is only for a short period of time.
Yeah.
So till, as someone told, that when we want to transfer the patient, or till the action of corticosteroid we have established.
Correct.
And if we have given magnesium sulfate as for the neural, So for this thing,
neuroprotection.
And
Perfect.
once the pains are gone, then we can stop tocolysis.
Okay. So we have already talked about this, and definitely initially you have been given with the examination findings, but still suppose, sometimes it happens that patient doesn't give you the history of leaking. I'm sure all of you have experienced this, that she doesn't tell you that she has had leaking. She just goes to the toilet and, she passes some liquid. She feels that she has urinated, and later on maybe the liquor is drained out. So she may not even have leaking. Right? So there comes the role of, per speculum examination. So there also you have to see whether she really has PROM. If she is in doubt, you may have to go for these, even if on per speculum examination, you ask her to cough, and even if no liquor is coming out, you may have to go for nitrazine test. What is this? Insulin-like growth factor binding protein test. I'm sure many of you have used it already. We have talked about the tocolysis, and it's only long-term tocolysis is not at all recommended, and it has been, recommended only for, the rationale of use is achieved, as all of you have discussed it already. Now I'm going to I'm going to invite Dr. Girish sir for his comment about the entire case. Girish sir.
Sure, I would like to comment upon this. Since that is, you have put it the evaluation very nicely, and preterm labor has come a long way. So the first, bed rest, hydration, opiate analgesia are out. Alcohol, opiates are no more to be used. Hydration has no role. In fact, even bed rest, strict bed rest has no role. But confinement to certain extent, that avoiding strenuous work and hurried work are more important things, and take maximum possible rest is the advice. So total confinement in the bed is more detrimentally. In fact, head low is out of question. Head low is not to be given. Head low is out of question. After 70s, isoxaprine, ritodrine. Okay, isoxaprine you will find nowhere mentioned in modern textbooks. It is out. Still, I can see many people using isoxaprine, but isoxaprine has been proved to be outdated and of no use drug. So never use isoxaprine. It's of no use. It's a placebo. Ritodrine, it has its own side effects. It is dangerous if it is given supervision. And now come the salbutamol, terbinafine, Maxelf, and indomethacin. All are again have their own side effects, except Maxelf, which is much safer than other salbutamol and terbinafine. Basically, they are soft muscle relaxants, and do not necessarily have a uterine targeted action. So they are empiric in nature for using them. Reappraisal of beta-antagonists, concerns about pulmonary edema are very high. And lastly, the gradual drift away from beta-agonists towards nifedipine and atosiban. Now, nifedipine is much more useful. It's a calcium channel blocker, and it has a direct effect on uterine musculature and has been found to be very effective. Atosiban, though there are no phase 3 trials at present, It has not been approved by US FDA and Japan as yet now. It is approved in 67 countries, including India, but still needs a lot of experimentation. But it has been found to be useful.
Sir, thank you so much. Very well expressed. The evolution has really, guided us so very well. And people like you who have experienced all these drugs are the better judge. So we come to the second case now. And now I think we start from Dr. Meenal. We have this 38-year-old lady, Gravida 3, Para 2, Living 2. See, 2 living issues, still she is going for third pregnancy. 26 weeks of gestation, 2 previous normal deliveries. Now she comes to you with polyhydramnios, AFI 17 centimeters and with diabetes mellitus. Now she's coming to you with abdominal pain. When you examine her vitals are normal, absolutely. Uterus is 28 to 30 week size, little over distended. And she's getting contractions, 2 contractions in 10 minutes, each lasting for 15 to 20 seconds. Fetal heart is good. Cervix is 2 centimeter dilated. 50 to 60% effaced and membranes, maybe the TENS bag and station is higher. What is the diagnosis for this patient and how will you manage this patient?
Ma'am, this patient is 26 weeks, right? Okay. And 2 centimeter already dilated and 50 to 60% effaced. So this
I
patient
want you to comment on this dilatation first. Gravida 3, Para 2, and with polyhydramnios. Do you have any comment on this?
Yeah, this because it is a Gravida 3.
Yes, whether it
Because
is before labor also sometimes patulous cervix.
Yes. That is a
Multipara with
possibility.
polyhydramnios. Okay.
Yes.
But 50 to 60% effaced. Okay. So
So-
what is your diagnosis? You can go ahead.
So the patient is going into the preterm labor in this case, and having like diabetes mellitus also and polyhydramnios as additional factors.
Because of diabetes. Because of diabetes, you get polyhydramnios, maybe large size baby also. Yes.
This is a difficult scenario, whether we want to we really want to save this patient, so we will give tocolysis, then magnesium sulfate, then 26 weeks, so we definitely have to give corticosteroids. Observe this.
Any comment on the salvageability? What is the period of viability you feel from in our country? And would you really give steroids to this baby?
Yeah, because 26 weeks we need to know what is the baby weight of this like baby. If it is more than 1.2, 1.3 also, sometimes
No,
the
we are not
babies.
concerned with weight. 26 weeks, whether you call this as viable, what is our local setup, whether we can save this baby, that is what I'm asking you. We have just talked about in utero transfer, right?
Yeah.
So whether you will manage it at your level or you will shift this patient to the tertiary care center where you have the advanced NICU facilities, that is my.
So yeah, definitely we have to shift this patient to advanced center with the NICU facilities.
Yes.
If
But
she
then
delivers
before that, you need to start a tocolytic.
all this, yes, tocolytis,
Okay.
corticosteroids, magnesium sulfate, and then we will transfer that patient to NICU and tertiary care.
Okay, so purposefully I have put this, whether this is the threatened preterm or abortion. Definitely all of you know what is the question, what is the definition of abortion. All of us are well versed. 20 weeks we take it as the limit for defining abortion. Considering the viability as per your setup, whether this baby is really salvageable, that is what the question. This is only to confuse. But then what are the risk factors for this patient? That is what I was talking to you. What are the risk factors for this patient to go for preterm labor?
Uterine overdistension.
And also some infection as well can be. She's a
can be
yes.
because of diabetes.
Okay. So what kind of tocolysis you will use for this patient? What kind of tocolysis you will prefer for this patient? By the time you will give same thing again, but
Same
what
thing.
will you use, and whether you would like to give steroids, whether you would like
Steroids.
to give Maxel, which and how, what steroid you want to give?
Okay.
And similar management with same with nifedipine as a first line of management, and then for magnesium sulfate. Steroid actually will
What
usually
steroid?
work
That is
after
what I'm
28
asking
days
you.
of
See, basically,
steroid.
I'm asking you whether you should give steroids because she's diabetic.
Yeah, she is
Whether you
diabetic.
should
Ma'am.
give,
If she is,
yes,
yeah.
you have to give.
Yes.
But then she's diabetic, so what precautions, what problems it can
Ma'am,
create?
we will have to monitor the sugars. We will have
Yes.
to, she'll obviously be admitted in the hospital, but we'll have to monitor her sugars and alter the insulin doses or whatever oral
Yes.
hypoglycemic she's taking.
Perfect. Purposefully, I have not mentioned insulin because she's already diabetic, not GDM. Okay. She's diabetic, so she's on insulin already. And whenever you
Okay.
start steroids, there is a lot of fluctuation in the blood sugar level, and that is why we need to hospitalize her, monitor her sugar levels, and alter. That means increase the dosage of insulin. Okay. That is
Okay.
fine. So, which steroids you want to give and how much? Anybody from the panelists, it is open for all of you. Purposefully, I am not put the names.
Yeah, madam, usually we give dexamethasone.
Mhm.
Previously, we used to give betamethasone, but now it's dexamethasone only.
How much?
So we give 8 milligrams 12 hoursly for 3 doses. So
Okay.
total 3 ampoules we give.
Yes.
And
So
if
whether it is betamethasone or dexamethasone, the rule is IAP and FOXY both have agreed that there is a combined statement saying that any steroid for that matter will work 24 milligram over 24 hours. That is what it is. Otherwise, you say betamethasone 12 milligram, 2 doses 24 hours apart. Or maybe
Right.
dexamethasone 6 milligram 6 hourly, or as you said 8 milligram 8 hourly. So the conclusion here is 24 milligram over 24 hours.
24
That should
hours.
improve the lung, surfactant also. It should improve on the lung maturity of the fetus. What investigations you want to ask for these patients?
Sneha, just I would like
Yes,
to ask the
yes.
panel people, would you think of amniocentesis in this case? Anybody can take the question?
Amniocentesis.
Sir, when I was a PG, our PG teacher used to do amniocentesis. That's only for one time we saw amniocentesis in case of polyhydramnios to reduce the chances of like pain, and because she was feeling very discomfort. But we have never done such.
But now since this patient is
since
in
she is
preterm
diabetic-
labor, since this
So
patient
she's
is in preterm,
diabetic.
yes,
So I would, the patient is diabetic, so I would not attempt any invasive procedure in this case.
okay, fine.
Yes. Okay. So what will be the management apart from routine, whatever you have talked about, the in utero transfer we talked about the analgesia if there is a significant pain or analgesia, tocolytics, steroids, magnesium sulfate, and then of course discuss the plan with the woman as well as the family, because you're not sure polyhydramnios, getting uterine contractions, os is dilated, tense bag, anytime it can rupture also. So you really need to Dr. Girish sir is here, and definitely the medico-legal aspect comes into picture. You have to counsel the woman as well as the family very well. You have to take everything in writing and informed written consent before going for any management. Otherwise, act of commission may happen here, and you have to really be very, very very thorough with your clinical judgment and management. So we have discussed about all these aspects, and this is just a theoretical aspect, what level the beta mimetics work and all this. Here comes the main role of atosiban. If the patient is really having contraction when the uterus is tense, so this is a very, very good drug. I hope many of you must have used this. And the tocolytic agents, though there are so many, atosiban is recommended for the management of preterm labor. Nifedipine, as all of us have been using, because it's a cost-effective drug. But atosiban, if you consider the cost efficacy in terms of, the NICU admissions and the very high cost, this is definitely going to be very, very cost efficacious. So that is what I'm telling you by my experience also. Nowadays, the cost has also come down. Previously, almost 35,000. Now it is come down to 20,000 and even lesser than that. So this is what the schedule is. If at all somebody wants to know, it is available as 6.75 milligram ampoule, and it is given slowly over 1 minute. The IV loading infusion is 300 microgram per minute. It is given for 3 hours. And maybe if first 24 hours she responds, you can continue it up to 45 hours. That is what it has been recommended. But nowadays they have come up with, even the bolus in first 3 hours. The infusion should make you relieved of the uterine contractions. That is what it has been quoted. I'm not experienced with that kind of regime, but definitely it's a good relief for preterm labor as such. So we have discussed all these steroids and magnesium sulfate for neuroprotection. Anybody can talk about the neuroprotection. I think Saman, Ashwini Pawar, both of you can contribute to this. How much should be the magnesium sulfate and how it should be given? Yes.
Yeah, magnesium sulfate loading dose 4 gram as a loading dose, and then followed by 1 gram per hour for 24 hours. We usually give as it is. When we are actually this should be given when we are predicting that that patient is going to deliver in next 48 hours. So it will be useful at that time. If we are predicting that no, we can conserve this patient for more days, 1 week or 2 weeks or more, then it don't have any much
yes, but
if
but
Ma'am, this patient will, if we are starting magnesium sulfate, we will have to monitor for respiratory rate, pulse, urine output, and the deep tendon reflexes.
Naturally, you are giving magnesium sulfate in whatever dosage you're giving intravenous. Even the loading dose that is same as how we are giving it for eclampsia. Okay, the diluted ones, all of you know how to prepare 4 gram, 4 ampule, 8 ml, and in 12 ml of normal saline. That has to be the proper way. And of course, meanwhile, whenever the patient is on, it is very difficult to give this magnesium sulfate as a, with the routine pint and IV set. You can have micro infusion pump, or maybe you have 5 grams in 500 ml of saline and you give 100 ml per hour. That is how you can make it very simple. That is how we have been doing. So you have to monitor this patient. There is no alternative for this. So definitely, but you don't know when the patient is going to deliver, because the patient is, you are suspecting that she's going to deliver preterm. That's the reason you are giving this magnesium sulfate. So you could stop. This has a dual effect, the tocolysis as well as the neuroprotection. So once you could, achieve the tocolysis effectively, maybe you can pull on this pregnancy further. That is in a way better for the baby as well. So definitely we will have this discussion theoretically later. But what are the problems with preterm baby, if at all? Why are we worried so much about the preterm delivery? What care should be offered?
So the most important. Hello?
Yes, yes.
And so the most important factor we are worried about is the lung maturity in preterm babies. Then the weight of the baby. They are low birth weight babies. They are prone for hypoglycemia. They are not able to maintain their body temperature. So they will need a warmer. And even while transport, we will need to give them some warm blanket or something, even if they deliver at a center and we want to transport. And they are prone for retinopathy of prematurity, hearing defects, and feeding issues are there.
Yes.
Then they are prone for neonatal jaundice.
Yes.
Might go in
Hypoglycemia, hypothermia, hypocalcemia, and prolonged neonatal jaundice. Okay.
Septicemia, necrotizing interval, lot of things with preterm, associated with preterm.
Yes. Any intracranial complications?
Yeah, intracranial
cerebral
hemorrhages.
palsy, seizures. Okay. And of course, the cardiovascular, you may have that persistent fetal circulation, PDA and all this. And then, of course, the metabolic complications. Long-term sequelae also will be there. No, you know what is, even if you try and, overcome all this situation, I'm sure you all have faced this in your practice also, because for this baby, you give 100% oxygen or hypoparic oxygen. And the retrolental fibroplasia, which happens, there are many cases all over India. Sir must be aware of it, leading to some issues on blindness.
Yes,
So
yes,
we save
particularly.
these babies and they land up into retrolental fibroplasia and
Yes,
permanent
I wanted to come to
blindness.
that. Yeah.
Yes.
So, endoscopy is mandatory in preterm babies. Please note. Because many of the cases have gone against the doctors just for not performing fundoscopy and not detecting retinopathy of prematurity earlier.
Yes. So that is what the message, very very well given by sir. So we go to the next case now. We are taking short cases, similar ones, but then we have to see what is the difference in the management for each and every case. Here we have this 28-year-old primary gravida conceived with IVF, twin gestation, 29 weeks, and she presents to you with labor pains. Vitals are normal. Uterus is 28 to 30 weeks. Head is floating, and she has 3 contractions in 10 minutes, each lasting for almost 25 seconds. The cervix is dilated 3 centimeters, 60% effaced. What is your diagnosis, and is there any role for circlage? Yeah. Whom should I? Meenal, Dr. Meenal Chitgupkar.
Yes, madam.
Please.
This
We want to hear from you.
yeah, this patient is going into full abortion phase where she is having contractions also
29 weeks,
and
my dear. 29 weeks she is.
Which
Preterm
one?
labor.
preterm
going-
labor. Sorry. Preterm labor, and with the 60% effacement and 3 centimeter dilatation, this means it is a
Established.
established one.
Yes.
So
Yes.
in this case, there is no role of cerclage. Here we just want to give tocolytics. If as previously said, we have to with giving corticosteroids and magnesium sulfate, we have to shift this patient to a proper
Tertiary.
place where tertiary care center where NICU is available. Here we cannot try anything for salvage with the help of cerclage.
Yes, yes. But in this situation, can you transfer this patient to the tertiary care center? She may, have rupture of membranes, or she may even delivered on the way. But then by the time you want to send her, you have to manage her, you have to quiescen the uterus, right?
Yes, right. Or maybe we need to call neonatologist at our place, and then after the delivery of the baby, then they can take that baby to NICU. Like that, if before.
Okay. This patient who has got, almost, very significant uterine activity, uterine contract. Dilatation is also very significant. So you have established preterm labor. Okay.
Preterm labor, yes.
So before transferring, see, if you don't have the facilities, you may think of transferring, but in this situation, you cannot transfer her. You have to make her uterus relax first. See that, you get some time to give steroids and magnesium sulfate, and by the time, if at all, you get some time, you can do that transfer later on, little later. Okay. But then, meanwhile, if she delivers with you, definitely the neonatologist should be the one who should manage. And then if you have a chance to even shift the baby to higher center. Okay. So here now established preterm labor, almost established preterm labor. So here comes a very important role of atosiban. So here comes the role of atosiban, where you actually have those contractions. Okay. Yeah. So atosiban will definitely help you taking this at least to 3-4 days, maybe at least. Okay. So if you can stop the contractions, definitely, and you allow the uterus to become quiet, maybe she will not rupture her membranes. So by the time all your drugs have worked, and even if she delivers, it's okay.
Okay.
But people have tried, even with such cases, people have tried, because those people who have done rescue cerclage, they're very
Okay.
they're very fond of it, and they're very confident about this, that even if at this stage, once you quiescent the uterus, maybe you can go for the rescue cerclage, because once you close the mouth of the cervix, you have good support and the chance of PROM is avoided. So this has
Okay.
been shown to improve or continue at least for 4 to 5 weeks, which may, lengthen the duration of pregnancy, which can be helpful for maturity of the fetal lung. That is what the claims have been. But
Okay.
let me share with you that I have no personal experience of, extensive progress labor and going for rescue cerclage. I have done almost 10 cerclages for 1 to 1.5 centimeter dilatation, but not beyond that. Okay.
Okay.
But people
Yes, ma'am.
who have done, there are many papers, and then of course they recommend this monitoring of this fetus also by NST. They keep the patient at bed rest with head, leg end elevated, and support by the os cerclage, whatever they have done now. And here also you need to differentiate. When you talk about the reactivity of the NST, anybody wants to talk about this? Dr. Ashwini, how do you say that the NST is reactive or non-reactive?
Yes. Yeah, the baseline should be around between 120 to 160, and variability should be 5 beats per minute, and there should be 2 accelerations at least of 15 to 20 beats per minute, lasting for 10 to
15
lasting for
seconds.
20 to 15 seconds. So in that way,
At least 2 acceleration in that 20 minutes period. Okay. This is what you're talking about, the term baby. But what we are concerned here, yes. So why I'm discussing this point? Yes, because when you are monitoring this preterm baby, the variability defined, it is defined differently. It is 10 beats per minute, lasting for 10 seconds, and over that 20 minutes recording. Okay. So whenever you are monitoring, otherwise you feel, oh, this fetus is not reactive because it doesn't have 15 beats per minute. So there is a difference in monitoring of the term and the preterm baby. Okay, so that is how you can prolong this pregnancy ahead. So one aspect we are covering, this is the monitoring of the fetus, of the preterm fetus. Okay, now we go to the next case. Here we have this 30-year-old lady, para 2, with 14 weeks gestation, previous 2 preterm deliveries. And now 27 weeks, 27 weeks and 25 weeks respectively. Now she comes to you for antenatal checkup. On ultrasound, you have cervical length of 3 centimeter. Os is closed. How will you reduce the risk, and what investigation? Do you label this as short cervix? Do you go for prophylactic os tightening? Because this is why this is called as prophylactic, because by definition, if the cervix is less than 2.5 centimeter in length, then only we call it as therapeutic, because the short cervix is defined that way. So how will you reduce the risk for this patient?
Initially, ma'am, we have to educate the patient about preterm ligaments. Actually, she already have 2 previous preterm deliveries, so she may be knowing the thing that how the delivery pains are there. So, but still, we have to inform her that you may end up again with the same situation. Then we initially at this stage, we first we should we should rule out any infection, vaginal infection is there. We should treat that infection, and then with progesterone supplementation, we can continue with the pregnancy. Vaginal progesterone or weekly progesterone, 17 hydroxyprogesterone.
Yes,
Every week.
but then
and then circulate at
with 2 previous preterm deliveries.
Ma'am, there is a role of
yeah,
there,
circulation
ma'am,
is
I would
essential.
like to offer cerclage to this patient based on her history.
Yes.
Yes.
Anybody else in the panel?
Madam, we can again do a repeat. She is definitely a high risk patient for preterm delivery. So as she has pointed out, we have to see whether there is any bacterial infection, any urinary tract infection. We have to rule out that. Some other problem associated at 27 and 25 weeks. APLA also we should rule out.
Yeah. So
I would,
basically, you're right. But then what this patient specially suggests is, see, whenever you have previous 2 preterm deliveries, a
it is better
prior
to
preterm delivery itself is a very high risk factor. And when you have 2 preterm deliveries, it's a very, very high risk pregnancy. So definitely you have to rule out the other causes of preterm labor, as you have rightly pointed out. And for that, you have to rule out the uterine anomalies, whether she has, some
yeah. So basically, we have
cervical
to find out
surgery also
causes for
previously.
this.
Yes. And what else?
Madam, a detailed history has to be taken that previously whether they were painless abortion or whether they were abruption, like she has bleeding, history of bleeding in the previous pregnancy, whether cervical encirclage was done at the second time of this thing. Because if it is a failed cerclage, then again she becomes an high risk, and then we may have to refer to a tertiary center where maybe they do abdominal cerclage.
Okay.
Also, we have to ask whether the baby was anomalous or no, because even anomalous babies lead to preterm labor.
Correct.
And basically, we have to know her whether there was associated polyhydramnios, oligohydramnios, placental abruption, any previa, because those are also causes for preterm labor.
What
So,
about RH negative?
Yes, RH negative can also lead to preterm labor.
So all
But
these
all these causes of preterm
factors
labor mainly need
have
to be
be
looked
ruled
at.
out first. And
So
if she
detailed
doesn't
history is
have
very
any
important.
of this, best way is to go for cervical cerclage along
At
with
13
the
weeks.
vaginal progesterone. Okay.
Yes.
The injectable progesterone, oral progesterone has not been proved effective in such kind of patients. Okay. Prior preterm births, 2 prior preterm births basically rule out other etiological factors, because here the cervical length is 3 centimeter and os is closed. Okay. But if you rule out other causes, in spite of that, if she doesn't have any other cause and still she is landing up into preterm labor consecutively, even with this cervical length of 3 centimeter, it is justifiable to go for cervical cerclage and then, of course, the vaginal progesterone. Dr. Girish sir, you want to comment on this patient?
Yeah. I want to just ask the panelists one question. At what time would you start the progesterone? Just in anticipation that she might deliver prematurely, and you want to prolong it as long as possible, because these days I see progesterone given right from 6 weeks till term. It is just just a blanket given, just therapy, which is of no use. But particularly now the first time the subject of progesterone in preventing preterm labor has come, and that is a genuine participation of progesterone when previous preterm deliveries were there. It is a known role. Progesterone is a known role. But at what time would you like to start it?
Ideally, they say at 16 weeks, sir.
Sir, according to
14
history,
to
when
16
preterm
weeks.
labor set up previously.
14 to 16 weeks.
14 to 16. Second?
Sir, according to her history, when she got previous, so 2 weeks prior to that.
Yes. Any other? Yes, Neha, would you like to add to it?
Yeah. So definitely, I have talked about, this patient actually, she's not landing up into threatened abortion or spontaneous abortions. So basically, right from early pregnancy, this patient may not need the progesterone. But if you see the mechanism of progesterone, how it acts at all the levels, nowadays the concept is coming, sir. I will show you the diagram which is there initially, that it acts at all the levels, right from, the uterus and cervix. Even the decidua and the fundus of the myometrium of uterus and the cervix and the membranes and placenta, at every level it works. So the concept is right from early pregnancy, you should prescribe or you can prescribe progesterone as long as you want to pull on the pregnancy.
Yes, but not for all patients, including primaries.
Yes.
So that should be the message that should be
For
passed.
the high risk pregnancies, for the high risk
Only
pregnancies.
for the high risk and preterm predisposed pregnancies. But you can see, Sneha, the prescriptions of particularly the generation.
Yeah.
From 6 weeks onwards, they continue progesterone till lifelong.
Yes, that I mean that is not, that is what we are talking only about the high risk pregnancies.
Yeah.
Definitely, what we have discussed is the patient who has had two
High risk,
previous
yes.
preterm
Predisposed to
deliveries.
preterm labor, yes.
Yes, here comes the role of the comprehensive history, as we have discussed. The counseling, as far as you know, she has to stop smoking or alcohol. Nowadays, these factors are also come into picture, which were never before. And then, of course, the psychological counseling, and then the relaxation, because stress can be one of the major factor for precipitating abortion or preterm labor. And then bacterial vaginosis, what we have been talking, not only the active infections, but the bacterial vaginosis. So offer screening for all this, even asymptomatic bacteriuria, bacterial vaginosis. So screen and treat all these women. And cervical length, because she has had two prior preterm deliveries, at 11 to 13 weeks, you can note the cervical length, and there is what is called as dynamic study for the cervical length. So transvaginal sonography, and you see to it that not more than if you have the shortening of the cervical length by 4 millimeter, then definitely that is a patient. So absolute length of the cervix is not considered for such cases. If you have in 2 weeks, if you have less, the length is reduced by more than 4 mm, that is an indication for the cervical cerclage. That is what it has been discussed. Then that is where the role of transvaginal cervical length serially from 14 to 24 weeks. So this is how it has been discussed. Risk reduction, this is actin partus. This is a qualitative evidence, and it is designed to detect the phosphorylated IGF-BP, as we have talked about it in cervical secretions. Then, of course, you have this IGF-BP1 protein, which is lining the uterus. Of course, fibronectin, all of you know this, fetal fibronectin. So screening test to detect, and nowadays it is available at the metropolitan cities. For our town, small town like Yavatmal, it is not available. So all this, quantitative and qualitative test, both of these. So cervical length, transvaginal sonography, and dynamic study, that is the most important for us. Wherever facilities available, so now we talk about what are the roles of all these, progesterone, cervical pessaries, cervical cerclage, and combination. I would ask now Ashwini and Pratibha. Pratibha, I want you to comment on all this. What are the treatment options? Do we have Dr. Pratibha?
Hello. Ma'am, we can offer progesterone. I just mentioned that progesterone we can offer to patient vaginal progesterone or weekly progesterone, injectable progesterone for to avoid preterm labors. And the cervical cerclage after anomaly scan, after ruling out anomalies, then we can go ahead with cervical cerclage. Cervical cerclage, I will say that the case we discussed previously, I think she's very high risk patient for a preterm labor. She may land up. If we reload other things, then we can go ahead with
yes. That is what we discussed. That if she doesn't have any of those high risk factors, even if the cervical length is 3 centimeter, it's better that you go for cervical cerclage, and that is how I have labeled it as prophylactic cervical cerclage. Okay, but you continue with the vaginal progesterone because it's a third pregnancy now. Okay. Any experience on cervical pessaries, or have you heard about some of the studies on cervical pessaries?
No, madam. I have never used actually cervical
pessaries for preterm labor.
Okay. So see what the evidence is that spontaneous preterm labor, that is or mid-trimester losses, 16 weeks onwards.
CT abdomen किया तो?
Girish sir, this is the answer for your question. So if the patient is low risk, maybe we start 16 weeks onwards. But then if the patient is high risk,
somebody is talking.
सब clear है, don't worry, we have already given the report.
Somebody is talking in between.
Yeah, somebody is talking in between, right?
Now please repeat the question, madam.
We already made the report in your favor. We have submitted it. पिछले हफ्ते
Who is talking in
Saiki,
between? Please mute
can you
yourself.
please mute others?
अभी अभी क्या
Okay,
करेंगे
ma'am.
मालूम, किससे मांगना वो भी मुझे मालूम नहीं। अभी 2-3 दिन जाने तो फिर
I think it's Sanam. Please, yeah, you can.
Yeah, I did mute somebody, but then okay. So offer the choice of prophylactic vaginal progesterone, or the FIGO has endorsed that short cervix, cervical sucklage and vaginal progesterone, they have they are equally effective. That is what it has been endorsed. So depending upon your choice, come merit basis, whatever you feel that you are comfortable with, I think they are comparable results. So if you have the cervical length of 25 mm or less than 2.5 centimeter, you can go for either cerclage or vaginal progesterone. It is, of course, by the informed written consent of the patient as well after counseling, proper counseling.
And I would like to add, Sneha, in
Yes,
this one
yes,
thing.
yes, please.
Even addition of nifedipine, even the patient is not hypertensive, addition of nifedipine does help in these predisposed patients, along with progesterone, vaginal progesterone.
Yes. As we have been talking about that, it is a good tocolytic.
Yes.
So whenever you are suspecting some sort of uterine activity, I think that's a good indication where you can start with nifedipine. But if it is only short cervix, where there are no contractions, then definitely cerclage or vaginal progesterone.
Yes.
Madam, I have a question.
Yes.
For cerclage, and we are saying the vaginal progesterone. What dose of vaginal progesterone we are looking at?
Who is this?
I'm Dr. Meenal Chidgupkar.
Okay.
I just want to know what is the dose this recommendations consider that we should give to avoid this preterm labor in cases of when we are using progesterone.
Ideally, see, vaginal route has been described as the best route possible where you have the maximum absorption of the progesterone. So actually it is around 300 milligram per day. But people prescribe 200, maybe even 400 twice a day.
400 3 times a day sometimes people prescribe.
Yeah. So we need to be we need to have the evidence to follow. So it has been discussed as and described as 400 milligram per day. So it can be in 2 divided doses, 200 milligram twice a day. Yes.
Okay. Thank you, ma'am.
And then now we talk about the vaginal progesterone. We have already discussed that 16 to 24 weeks of pregnancy, whenever there is short cervix, then that is an indication for vaginal progesterone. This is a SCOG committee opinion where a woman with singleton gestation, this what I have just discussed, SCOG, Foxy, Figo, every organization, they are now advocating vaginal progesterone in place of the cervical cerclage. We obstetricians are the better judge, but if you have the evidence of cervical length of less than 2.5 centimeter, you have every justification to go for cervical cerclage if you are comfortable. Otherwise, vaginal progesterone is recommended as management option to reduce the risk of preterm labor in asymptomatic women with a singleton gestation. That is what it has been discussed. But then if you have a very short cervical cervix, better go for the cerclage. And this is what I was talking about, the Arabian cervical pessary. There are some centers in India, I think Malhotras in Agra and 1 or 2 more centers in Kerala. They have been using such kinds of Arabian cervical pessaries to reduce the preterm birth and they have some studies presented. I personally have no experience about this, so I'm not the authority to talk about this. Any comment, Girish sir, from your side?
No, as you said, we really don't have a experience about the pessary, so we cannot.
Okay, sir. So we go ahead with the last case, I suppose, and then we hand over to Monica. We have this primary gravida conceived after 7 IVF failures. Okay. Conceived after 7 IVF failures. At 24 weeks of gestation, she comes to you in casualty with complaints of leaking per vaginum. Vitals at present, they are stable. Uterus is only 22 weeks, regular. The fetal heart is regular 132. But yes, per speculum, there is a frank leak. Ultrasound shows single live intrauterine gestation of 24 weeks, single largest pocket measuring 2 centimeters. How will you manage this case? Very clear question whether you want to conserve first or you want to let it get terminated, or you will actively terminate it. Saman and then Sujata.
Ma'am, this is the patient.
It's a very traumatic for the patient, madam.
And it
At
is very
24
traumatic to
weeks.
hear the history
Yeah,
also.
I know.
Yes.
So Saman,
Yes,
we would
yes.
like to hear from you. How would you tackle this patient?
Ma'am, first I would counsel the patient and explain the situation to them. And then I would like to, I don't know, I'm also really disturbed by this
Okay.
question.
Sujata, you can take further.
Yes, madam. Actually, she is 24 weeks. Maybe if
Yes.
she is in Solapur, it is very difficult for this baby to be salvageable. And lighter is almost 2 centimeters, so it is almost nil
I
lighter.
have heard one of your neonatologists who is from Solapur, I forgot his name, in Amogs, I think Aurangabad, who has, really tackled those very small 500-gram babies.
Yeah.
Yeah. So,
Yeah, so
I'm sure
yeah,
that
we have to be positive and we have to try everything.
Yeah.
Maybe she will do spontaneous labor after sometimes. We may not do anything actively. Just we can give her steroids for her and our sake, but we have to counsel her. We have to tell her that this is what is going to happen. Even sometimes this baby come live, means when they are born, they are alive. And then at times it is very difficult
No,
because then the
Sujata, we will talk about it later. I'm asking you, this patient has come to your casualty. You have counseled, but what you have counseled, let us also know.
yeah, we have to counsel so that the liker has reduced. Now, if we do anything, there are we cannot conserve this pregnancy. You may go in spontaneous labor like that also.
Would
So I
you
would
tell
like,
her right at the first moment? Would you tell her, or you will give her some, some positivity? You will explain her. Have you experienced sometimes that such patients, when you just make them go for conservative management, the amniotic fluid keeps on increasing, and sometimes this pregnancy continues. Maybe for few weeks also. Okay.
we have to try our best for all preterm labor. Even if we can prolong this for 4 days, 1 week, and if there are no signs of chorioamniosis, we can just wait. Sometimes it means I don't know, madam, because 7 IVF failures, maybe sometimes we feel that we should give Autosiban, what we should do, what counseling, it's really very difficult. We can take one opinion of one other gynecologist also.
Yes.
So we can take 2 of us, we can some discuss, we have to take pediatrician also in account.
Yes.
Because this is really a precious pregnancy for that. Of course, all
That is what I'm
pregnancies
trying to tell you, that 7 IVF failures, and now she has come to you with this situation. You will not tell her directly something negative. You have to definitely tell her that the way you have presented, it's very difficult for us to take this pregnancy ahead. But definitely we will try our best, but everything has to be written, because all the time the medical legal experts know. I have to keep a watch on Girish sir also, that you have to really take everything in writing, because it's not your fault. You are trying to do something better for her. So you tell her that we're going to give steroids, we're going to give magnesium sulfate, we are going to give antibiotics if at all, she's have frank leak. And then of course, whatever hygienic, precautions you have to take. And maybe miracle can happen. Maybe this pregnancy can go ahead, but maybe she can go into spontaneous labor and she can, at once deliver, and we have nothing in hand. So you keep your NICU also informed, and you keep everything ready.
Yes,
Then
I would
you
say,
try for her.
I would say use every weapon in your armamentarium to help this patient.
Yes,
Whether
and
it
that
helps
is
or
why
not is
so
the
many
comment.
queries I have put here. You really have those questions in your mind, but definitely you are, as an obstetrician, you have lots to, do interventions here. This is the perfect start from Monica's talk. And I think I can share with you, one of our I will not share the name because the person was there in your medical college also from my place, Dr. Almost 3 months we have prolonged the pregnancy, and 35 weeks, 34 to 35 weeks we have the patient. Some doctor's wife had leaking at the 24 to 26 weeks, and with all the precautions, without cervical circlage, we have taken her ahead almost by 10 weeks. So miracles do happen. May not be our efforts. You can say it is just the success, but then there are many cases which we have actually not presented anywhere. Definitely clinical practice, you do have, all of you do have some cases, but this is of course a guarded judgment you have to share with the patient. But whatever in your hand you can do for the patient, you give, try to prolong. And then there comes the role of feto-maternal monitoring, where I have shown you the NST you do weekly and ultrasonography also weekly. See that the liquor inside is quite sufficient to survive the baby, and see also that the baby is doing well, so that we can pull on the baby till the period of salvageability at least, if not maybe few weeks, because every day in uterus saves your 1 week in NICU. That is what the most important message I feel. And on this note, I did end this discussion. First of all, I thank Girish sir for his inputs, very valuable inputs.
Thank you,
And
Sneha,
I'm
for
sure
giving
you
me
are
this
going to, I'm going to invite you for your inputs also. And I thank all the panelists. Over to you, Girish sir, for your comments.
As excellent, Sneha, all the cases were excellent, thought-provoking and guiding cases, and almost everybody who has seen this will be benefited. What I would like to say is that preterm labor is a sort of problem to, not to the patients also, it's a problem of the consultants also. But try to give maximum possible to the patient in all of your armamentarium, provided it is a rational use of everything. So be rational in using. Don't put the patient in unnecessary jeopardy, but try to help the patient all the way with all your possible assistance to the patient.
Thank you so much. Thank you, Girish sir. And over to you, Monica Umbardan, for Monica Singh's talk. Thank you.
Thank you very much, ma'am. Thank you, all the esteemed panelists. Thank you, Kumtekar sir, and thank you, Sneha ma'am, for an excellent panel discussion and a very wide variety of inputs, which we have good take-home messages. We now move forward to the talk, and I request Monica Singh madam to please deliver her talk, and Meena Gunjatikar madam to then conclude her talk after.
Thank you so much for bearing with me. It was a new Mac which was not allowing the keynote presentation to happen. So I will cut short my talk understandably, but it has to have important points on antenatal interventions which can help in perinatal outcomes. And for my talk, most of the guidelines have been taken from WHO. So they actually pertain not only to India, but all lower and middle economy countries where patients like us exist, whether it is Bangladesh or it is parts of Africa or it is Southeast Asia or India or Nepal. So these guidelines were first formulated in 2016, and they were formulated with WHO in association with all these bodies, which are very significant as far as perinatology is concerned. Now, what is perinatal period? Next, perinatal period actually means the period from, now the definition has shifted to 22 weeks of gestation. Right from 22 completed weeks of gestation up to 7 days after delivery is the perinatal period. So the background of my talk is antenatal care is critical, and we have to have timely and appropriate evidence-based actions which are related to health promotion, disease prevention, screening and treatment. And what is the objective? The objective is to reduce complications from pregnancy and childbirth, like all of you have been discussing, even for babies as tiny as 24 weeks, reducing stillbirths and perinatal deaths, which are very tragic, and integrated care delivery throughout pregnancy. To this end, we earlier had the ANC WHO ANC model of 4 visits. Now, this is what we studied previously, And they were specific evidence-based interventions for all women carried out at 4 critical times during antenatal period. This was also known as FANC or Focused Antenatal Care Model, but this had some disadvantages as we will see. Next slide. So, what WHO wanted and what the health sector of the world wanted was quality through continuation of care or continuum of care. And WHO envisioned a world where every pregnant woman and newborn receives quality care, respectful care throughout pregnancy, childbirth, and even the postnatal period. So, here it was the person who was centered for health and well being by reducing mortality, morbidity, and providing respectful care, taking into account the woman's own views, what she wanted, where she wanted to be checked. Did she want to go to a clinic? What would she want a health worker to come to her place? Were her family members cooperating? And the service delivery had to be optimized according to the place, whether it is Yavatmal or it is Bhopal or it is Mumbai. So, all women want a positive pregnancy experience. This is the underlying message from WHO, that is positive pregnancy experience from antenatal care. What does it mean? A healthy pregnancy for mother and baby, which includes preventing or treating risk, illness, and death. Physical and socio-cultural normality. You cannot tell the patient you wear a gown if she is living in a rural area. She will have to wear a sari. Effective transition to positive labor and birth. The birthing has to be a positive experience. Plus, you have to have a lot of positive motherhood feeling, including maternal self-esteem, competence, autonomy. She may want to join work after 15 days, after a month, so her autonomy, her wishes have to be respected. Next. So, how did these guidelines actually came into development? The 2016 ANC guideline package is a core package of antenatal care that all pregnant and adolescent girls should receive. In the middle of this webinar, I was reading the statistics, and tragically, as recently as 2015, we have lost 3 lakh mothers in antenatal and perinatal period and over 25 lakh fetuses. Fetuses, I mean, they range from 22 weeks of gestation to term babies we have lost because of tragic circumstances like mismanaged antenatal care, PIH, infections, sepsis, and so many things. So we should have the flexibility to employ different options based on context of different countries, and each model for each country is different. Plus, they have to complement the existing guidelines. So these interventions were divided into individual interventions like antenatal testing, who are the barriers, who are the facilitators, and the health system interventions. Next slide, please. So the DECIDE framework was made. This framework was based on 3 technical consultations with the GDG, that is the Guideline Development Group, over a period of a year, and collaborative effort between WHO departments, methodologists, and different groups of experts, taking into account even psychologists. So there were 3 types of recommendations which were made. Number 1, we definitely recommend this option. Number 2, it is provisional and we recommend this option only under certain conditions, either in the context of rigorous research or when we want to do targeted monitoring and evaluation or in specific conditions. And number 3, we do not recommend this option at all. This is how we are going to divide the recommendations. So the total recommendations are nearly 49, and 5 topic areas were divided by WHO. 14 recommendations are based on nutrition. 13 are based on how to do maternal and fetal assessment, like you talked about CTG, but CTG is not there in the recommendation. 7 are based on preventive measures. 6 are based on intervention for common physiological symptoms like nausea, bloating, edema. And 9 recommendations are the health system interventions at the level of the hospital, clinic, dispensary to improve the utilization and quality of antenatal care. A few remarks on this document is that I'll not go into detail, but a lot of detailed methodology has been provided, remarks, implementation, and the most important thing is if any of you refers to these guidelines, direct links are provided as to how to implement it. Next. So this is just, there are two examples of the type of recommendations you get. Basically, I am an ART person, but I found these recommendations so good because we deal with high IVF pregnancies. I've had patients, I'll just divert a little from the topic. I had a patient who conceived with IUI, and it was the second IUI cycle. At 24 weeks of gestation, she just came to me for a routine checkup, and I just put the TB probe and I could see the funneled cervical canal and the bulging membrane. So I put a speculum very gently using all aseptic precautions. I could see that bulging back. After taking proper consent, everything, because my husband, Dr. Andhir, is a lawyer also, he's LLB, I took the patient to OT next day for a rescue cerclage because it was very late night when she got admitted. And with proper precautions, sponge holding, we reduced the membrane, did a cerclage, but unfortunately, while just putting that knot, the membranes started leaking at one point. Now, even after this, we could prolong the pregnancy with the slow leakage for 2 weeks, but she delivered a 25 weeks preterm baby and that baby succumbed. This patient put me in court, and I had to be in court minimum 8 to 10 times, madam, before I could, get out of it without paying a single penny to the patient, because every court, whether it was here in MP, we have got the commissioner's court, the police department, the manhani, and all those things, So ultimately, I came out because it was not my fault. But sometimes when we try to do good to the patient, it backfires. So you can see how the recommendation has been made for counseling of healthy eating, physical activity, and there are beautiful recommendations also on intimate partner violence. Sometimes a pregnant woman is in a situation wherein she has to bear the burden of pregnancy, malnutrition, working at home, and again being physically abused by the husband or the partner. So this is a situation where antenatal care, again the healthcare provider and the grassroots level worker has to come into forefront in order to take her safely through the pregnancy and through delivery. Next slide. Next, please. So the recommendations, we come finally to the recommendations. Number one I'll be very short because all of us know everything. I'll just tell you what to do and what not to do. Nutritional recommendations. 1, counseling about healthy eating and keeping active during pregnancy. Yes. In undernourished population, nutritional education on increasing the daily energy and protein intake. Yes. Balanced energy and protein dietary supplementation. Yes. But high protein supplementation is not recommended even in undernourished populations. They are more concerned about giving a balanced energy and protein intake. Remember that. You cannot just tell the patient just have 2 eggs daily or have non-vegetarian diet twice a week. It may not be fitting into her socio-cultural norms. It may not be fitting into her budget and income. So remember to give the pragmatic approach to diet, which is fitting into your cultural conditions. A woman in Maharashtra would like to eat a particular set of foods. Woman in Madhya Pradesh would like to have something which is told by her mother-in-law and her mother. So we have to respect the woman's decision. Next. Nutritional interventions 2. Daily oral iron and folic acid supplementation is definitely recommended, but there is something called intermittent oral and iron folic acid supplementation, which has got a higher dose of elemental iron and a higher dose of folic acid. Now, this dose is given weekly. This is done in populations with anemia prevalence of less than 20%. So in basically healthier communities where the prevalence is low, you can even go for a weekly prophylaxis because, I found this very interesting because in urban settings, sometimes the woman is, reluctant to take a daily iron and calcium. There you can take this intermittent therapy into account, keeping into mind that my patient is in a safe zone. Similarly, daily calcium supplementation is recommended, but vitamin A supplementation is only recommended in those areas where vitamin A deficiency is endemic. Next. Next, we come to interventions 3. Zinc supplementation not required routinely, only with rigorous research or in specific conditions. So when the pharma people come to you, madam, you give a zinc tablet, it is not up to you to, say yes to that. Multiple micronutrient supplementations, nowadays fancy multivitamins are coming, not recommended. B6 or pyridoxine supplementation, not recommended. Vitamin E and C, not recommended. D, not recommended. And definitely nowadays women are taking lots of coffee. These are working women. They are taking 2-3 cups. So black coffee is very fashionable nowadays. So if caffeine intake is 300 milligram per day or more, definitely lowering that caffeine intake is recommended in order to reduce the risk of pregnancy loss. And it is also associated with low birth weight, though not with preterm delivery. Next. Coming to, so these recommendations were based on nutritional approach. Now coming to maternal assessment. Full blood count testing is the recommended method for diagnosing anemia. Where this full blood count is or CBC is not available, you can do an on-site hemoglobin testing with hemoglobinometer, but color scale estimation of hemoglobin is not recommended. Similarly, you should be able to do a midstream urine culture. Recommended method for diagnosing asymptomatic bacteriuria in pregnancy, and where the urine culture is not available, you can do gram staining, a simple test. And here again I come to intimate partner violence. Clinical inquiring, some leading questions can be strongly considered when assessing conditions that may be caused or complicated by IPV in order to improve clinical diagnosis and supportive care and subsequent care, and you may have to refer that patient even to a care center. Next. Maternal assessment part 2. Hyperglycemia first detected at any time during pregnancy should be classified either at GDM or diabetes mellitus according to WHO criteria, but we have got wonderful guidelines given by FOXI and by our Indian researchers also. Tobacco use should be, women should be warned, and she should be told about the risk of tobacco use and also the risk of being exposed to second-hand smoking. If somebody in her home or her partner is smoking, then all the pregnant women should be warned about the use of alcohol, substance abuse as early as possible. And at every antenatal care visit, you can even put posters in your clinic or in your consultation. And in high prevalence settings, you have to counsel about HIV. I'll not go into detail about HIV. And here where tuberculosis is endemic, you may have to screen for that also. Next slide. Coming to fetal assessment. Now, daily fetal movement counting and counting up to 10 is actually not practical. The woman has to be just aware of the baby movement, and it can be, just not every woman can be asked to keep a diary or something, which we used to do a decade or so back. Similarly, replacing abdominal palpation with measurement of symphysis fundal height for assessment of fetal growth is not recommended to improve the perinatal outcome. So if you're comfortable with the grips and the abdominal palpation, which you learned during post-graduation, the simple method, please keep following that. Remember, antenatal cardiotocography routinely is not recommended. It does not improve maternal and perinatal outcomes. Now coming to ultrasound, we are always confused as to now the NT scan has come, targets have come. So the WHO has given a blanket statement: one ultrasound scan before 24 weeks of gestation, that is early ultrasound, is recommended for pregnant women to estimate gestational age. Number 1, improve the detection of fetal anomalies, rule out multiple gestation, reduce induction of labor for post-term pregnancy and improve the overall woman's pregnancy experience. She is basically, she's happy when she sees the ultrasound. She's told that it's an alive baby. She hears the fetal heart and all that. But remember, routine Doppler is not recommended. It does not improve the maternal and perinatal outcome. And remember, I'm not talking in terms of the urban criteria. I'm talking in terms of the general antenatal population of every low and middle socioeconomic status country like India. Coming to preventive measures, number one, a 7-day antibiotic regime is recommended for all pregnant patients with asymptomatic bacteriuria because this is definitely associated with preterm birth and low birth weight. And Madam has just told us so beautifully to maintain all sorts of aseptic precautions whenever we are dealing with a case of preterm labor. Antibiotic prophylaxis is only recommended to prevent recurrent urinary tract infections. Antenatal prophylaxis with anti-D in non-sensitized Rh-negative women at 28 to 34 weeks of gestation is only recommended, again, research. And preventive antihelminthic treatment can be recommended where there is endemicity of this infection, parasitic infection, and TT, of course, is recommended for all pregnant women. Next. Coming to preventive measures too, in malaria endemic areas, sometimes intermittent preventive treatment is given with sulfadoxine pyrimethamine, but in India, it is up to the gynecologists or obstetricians to decide upon that. Similarly, when the patient has got HIV infection or you have a lot of HIV positivity, we may have to consider prophylaxis with the newer drugs. Yesterday, my daughter was discussing HIV with me. She's appearing for NEET PG. So she told me about these new drugs, tenofovir and disoproxil fumarate. So these are newer HIV, anti-HIV drugs which are coming up. Next. Now, how do you deal with common physiological symptoms? Here, again, the traditional approach has been approved by the guidelines like ginger, chamomile tea, vitamin B6, and acupuncture. All of them can be used for relief of nausea. And you have to give simple dietary and lifestyle advice to relieve heartburn and acidity. Antacids given routinely is not recommended. Similarly, leg cramps, you can use your magnesium, calcium, non-pharmacological option. For pelvic pain and low back pain, again, you can give lots of, exercise and woman's position and turn. For constipation, use of fiber supplements is recommended, and all sorts of non-pharmacological options are recommended. So there are lots of, positive things coming out of antenatal care. It's not all pharmacological jargon. People are going more into conservative traditional care, which we feel that the woman will accept better, and her positive pregnancy experience will become even more better. Next. Coming to health system interventions to improve. Sorry for the color of this slide is converted, Sahiti. But this slide actually deals with the the midwife-led continuity of care model, wherein, responsibility has been given to the grassroots level worker, the ASHA worker, the people working in CHCs, PHCs, because these are the people involved in antenatal care health systems of the government and even private practitioners who can even visit the woman at a place where she is comfortable. Next slide. So the implementation of community mobilization through facilitated participatory learning and action. Here, groups of women, antenatal women can be formed, or women who have recently delivered can give advice, recommendation, and sort of lot of emotional support to the antenatal women. And community mobilization, antenatal home visits are recommended so that the woman's antenatal care utilization and perinatal health outcome can be better, because there are some women who just can't, who are not allowed to move out of the house to get antenatal care. In that case, if there is a trusted, grassroots level worker who can go from the dispensary or CHC, PHC and go to the woman's home in that community, that will be a big boon to the perinatal care. Next. Coming to health system interventions to improve utilization, again, task shifting the promotion of health-related workers, starts shifting the distribution of recommended nutritional supplements, and promoting the recruitment and retainment of qualified health workers in rural and remote areas. So you have to train more and more of these workers to do basic training, palpation, inquiring about women's symptoms, doing simple bedside tests, learning to how to measure the blood pressure, seeing whether there is edema, seeing whether there are cramps. So these are all the things which a grassroots level worker can do and refer the patient on time. Next. Antenatal, and now WHO has given the antenatal care model of a minimum of 8 visits. So these are not called visits, these are not called consultations. To reduce perinatal mortality and improve women's experience of care, we need minimum of 8 contacts, and these are strongly recommended. Now I'll tell you what are the 8 contacts. Next slide. Next slide. So earlier, so why did this minimum of 8 contact come into WHO program? Now earlier I told you when the 4 visit ANC care model was there, we had increased perinatal deaths. So WHO was not happy with this program. So they decided to improve safety during pregnancy by increased frequency of maternal and fetal assessment, and improved healthcare communication and support around pregnancy, not only for the woman but also for the families. More contact between pregnant women and respectful, knowledgeable healthcare workers. See, the word respectful is coming again and again. You have to train the healthcare workers to have complete knowledge as well as respect the pregnant woman. And what was important was that there was no difference in maternal and perinatal health outcome between 2 ANC models. One ANC care model was formed with 8 contacts, and the other model included 15 contacts, but there was no difference. That is why they came to an optimum figure, something between 4 and 15. So the recommendation is for 8 contacts. Next. So remember, when it was a 4 visit or a 4-point program, the contact was first at 8 to 12 weeks, then 24 to 26 weeks, then 2 in the 3rd trimester. But now the recommendation is at least before 12 weeks, contact 1, number 2nd trimester, 2 contacts, and here at this time you should always recommend an ultrasound. The 3rd trimester, there are more frequent contacts, 30 weeks, 34 weeks, 36 weeks, 38 weeks, and 40 weeks. And patient returns for delivery at 41 weeks if she has not given birth till then. Next. What is contact and what is visit? The guideline uses the term contact because it implies an active connection between pregnant woman and the healthcare provider. That is not implicit with the word visit. Visit is like you visit a, you're a guest, you visit, you do the work, but contact means quality care. In terms of the operationalization of this recommendation, contact can take place either at the facility or even at the community level. So you have to adapt according to the wishes of the pregnant woman. Your core contact, your core person who is most important is the pregnant woman. And contact helps to facilitate context specific recommendations, whether in the intervention part or in the health system part. Next. Now, why did they talk about early ultrasound before 24 weeks? This I told you what is the indication. And an ultrasound after 24 weeks, that is late ultrasound, is not recommended. It is not recommended for pregnant women who have already had an early ultrasound scan, so as not to play burden on our healthcare systems. But the late ultrasound after 24 weeks can be recommended to those pregnant women who have missed somehow the early ultrasound scan. Now, this ultrasound equipment is costly. It is a luxurious item. So you can even use it for other indications like obstetric emergency, diagnosing placenta previa, going to the labor room, or even other medical departments. If the ultrasound machine can be shifted to the medicine department, so it can be done, and the implementation and impact of this recommendation on health outcome, facility utilization, and equity should be monitored regularly. Next. So the overarching aim is of this 8-contact WHO antenatal care model is to provide pregnant women with respectful, individualized and person-centered care at every contact, with implementation of effective clinical practices in the form of interventions and tests, and provision of relevant timely information, psychosocial emotional support by practitioners with good clinical and interpersonal skills within a well-functioning health system. See, interpersonal skills are very important, which sometimes sadly we lack when we were, doing 50 deliveries a day and seeing 100 patients per day in our PG period. That time we had minimum interpersonal skills. There is not a single postgraduate who has not scolded a patient in labor room and, who has not, been all the time irritated, but now it doesn't work like that. The health system approach has to be continuity of care, integrated service delivery, improved communication to the patient, give support to the woman. You should be having supplies, commodities, ultrasound machine, all the vaccines and everything available with you, iron, folic acid, and empowered healthcare providers. You have to recruit more staff. You have to retain that staff. How do you retain staff? You have to pay them well. You have to encourage them. And you have to build the capacity. Next. So I'll not be prolonging my talk too much, but there are a few slides on implementation, adoption, adaptation, and implementation of this model. Next slide. So this is M&E. M&E means monitoring and evaluation with the help of certain indicators and research questions. Next. And the dissemination of this knowledge. Next. Like we are doing this webinar. This is Sneha madam is disseminating this knowledge. So the relevant links are there. You go into these guidelines, beautifully you will get all the links of all the countries, how they work. And they apply, most of them apply to India also. Next. 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 So at the end of my talk, I would just like to quote Ban Ki-moon, who is United Nations Secretary General, to achieve the every woman, every child vision and global strategy for women's, children's and adolescent health. Remember, he has mentioned adolescent because there's so many adolescent mothers. We need innovative, evidence-based approaches to antenatal care. He said he welcomes these guidelines, which aim to put women at the center of the care, enhancing their experience of pregnancy as a positive experience and ensuring that each little baby has the best possible start in life. Now, I was in UK a couple of years back. So, they talked that being born British is like having the first class compartment in life. So that concept should come in India also. That being born in India is also a passport to, a good. Thank you so much. Thank you so much for patient listening.
Good evening, all. To improve fetal outcome, antenatal interventions are very well needed. Thank you, Monica madam. You have panoramically covered all the interventions recommended and in for positive and respectful care of pregnant mother till birth. It is very important, and you have covered all the aspects: nutritional, health workers, feto-maternal assessment, physiological aspects, and up to digital dissemination and links. It was very nice and wonderful talk. Thank you, madam.
Thank you. I really thank Amogs.
The organizers for giving me the opportunity to chair the session.
My dear, in fact, we should thank you. You are the organizer, and as the secretary of Solapur Obgyn Society, we thank you from the bottom of my heart.
Thank you, madam.
Dr. Vivek Virkar, sir, and Dr. Meena Gunjurtikar.
Thank you all the seniors.
Thank you so much. Over to you. Okay, Monica.
Ma'am, it was indeed a very enlightening talk, and it was carrying all the guidelines which were necessary. Thank you so much, Monica ma'am. Thank you, Sneha ma'am, for an excellent panel discussion. And thank you, Milind Shah sir, for an elaborative talk on kangaroo mother care. I would extend a heartfelt gratitude to all our esteemed guests today, Dr. P.K. Shah sir, Sardesai madam, Rohini Deshpande madam, Kumtekar sir as an expert, all our chairpersons, Labde sir, Guram sir, Ghate madam, Virkar sir, Gunjotikar madam for joining in and for chairing the session. All our panelists have done an excellent job through the questions that were bowled over to them. Thank you, Sahiti, for the technical support. Thank you, Madan, for being the coordinator with me for this webinar. Sneha ma'am, thank you for the opportunity.
Thank you, Monica and Madan, especially for working very hard and coordinating it so well. Thank you so much, Sahiti, for the flawless conduction of this program. Thank you so much. I echo the same sentiments as Monica and Madan. I thank all of you. Thank you so much.
And I thank you, Sneha ma'am, for inviting me. I thank a whole of Amogs. I thank Monica for the beautiful coordination. I thank Sahiti. She took my slides and ran them for me. So I have to now learn how to use Keynote. And to the whole Amogs, Pardesi sir and Rohini madam and magnesium sulfate wale
Suman Sardesai madam.
Sardesai madam, yes. So I have to now keep revising the names so that I remember. But of course, they are stalwarts, and I'm so honored and blessed to be amongst all of you, Sneha ma'am. Thank you so much.
Thank you so much. Thank